Anas, we are checking the sound. Can you hear us?
Yes, I can hear you.
Anas, is the interpretation working online?
يلا, let him.
Let's ask the. Can you please?
It's on.
Yeah, but بدنا نشوف إذا online.
Test. Do you hear the interpretation, Mr. Anas?
Yes, I can hear you now.
This is a test of the English channel. All right.
Okay, if there are any problems with the sound or interpretation, please do flag so that we're aware. But let's kick off. So, firstly, on behalf of the European Union, I'm immensely glad to welcome everyone today to this civil society regional event on understanding the impact of Captagon and methamphetamine trafficking in the MENA region. My name is Matthew Wilner-Reed. I work for the Foreign Policy Instruments.
في خدمة أدوات السياسة الخارجية مع إذن الاتحاد الأوروبي وعملوا على هذه المشاريع.
Counterterrorism, including the EU Act project, which is the project which is organizing today's meeting. And before we begin, I'd also like to extend some thanks, particularly to MENA. I have Ellie sitting to my left, which has been instrumental in organizing today's meeting and connecting with civil society across the region. Also thanks to all the civil society participants, notably from Tunisia, our host in a sense, but also people who have traveled from Jordan and Iraq, two of the countries most affected by Captagon and methamphetamine trafficking, as well as representatives from Spain, from the EU Drugs Agency, and from IDBC, UNODC, and of course all of those joining online. I'm going to provide just some brief remarks referring specifically to the law enforcement dimension, because where we sit, we look very much at the law enforcement direction responses. But of course, we're immensely interested to hear today also about the harm reduction and demand reduction efforts that are being conducted by civil society. So I gave these remarks yesterday. We've had 2 days of intensive meetings with law enforcement, also from across the region. I was a little bit nervous talking about human rights and in the context of law enforcement, but feel more comfortable doing so today with to a civil society audience. So apologies to those who've already heard what I have to say yesterday. But basically, I'd like to present on the need to develop evidence-based, human rights sensitive and humane law enforcement responses that avoid exacerbating social harms, which is something that
قانون التي هي قائمة على أو على مبدأ حقوق الإنسان، ولكن في هذا السياق أظن أنه من
about what law enforcement interventions can and cannot achieve. While law enforcement interventions are often successful in disrupting individual criminal groups, historically they tend to have much less impact on disrupting the overall drugs market, which is exceptionally resilient. Even in terms of the more modest goals of raising the retail price of illicit drugs, a review of the available academic evidence suggests that increasing the risk of arrest, incarceration, or seizure does not, in fact, raise prices at the targeted level, let alone retail prices. On the other hand, evidence suggests that increasing law enforcement actions may lead to increased violence. Indeed, a recent review commissioned by the UK government looked at all available evidence in this area and found that with the possible exception... Oh, sorry, I talked too slowly, too quickly for the interpretation. Apologies. I had the same remark yesterday. I'll try to slow down. A recent review commissioned by the UK government looked at all available evidence in this area and found that, with the possible exception of strategic deterrence, all other drug-related law enforcement interventions tended to lead to increased violence. This was also partially reflected in this year's UNODC World Drugs Report, which recognized that seizures and arrests cannot eliminate drugs markets and that crackdowns often drive insecurity. Also within the European Union, the recent evaluation of the EU's drug strategy noted that drugs usage continued to rise despite a context of increased arrests and seizures. Partially for these reasons, actors such as the UN High Commissioner for Human Rights, UNDP, the World Health Organization, and the Global Commission on Drugs have pushed to shift away from a punitive approach to drugs to one based in public health. In this context, it is worth mentioning that less repressive responses can also bring security benefits. An example of this is in terms of alternatives to detention. Over 2.2 million people around the world are imprisoned on often low-level drugs offenses, leading to overcrowded prisons and backlogged justice systems in many countries. However, the available evidence suggests that alternatives to detention actually reduce the risks of reoffending compared to imprisonment and deprive criminal gangs of one of their main sources of recruitment. The current EU drug strategy promotes increasing the use of alternatives to coercive sanctions and notes that drug possession for personal use is not a criminal offence in many EU member states. The UN Common Position on Drugs similarly promotes alternatives to conviction and punishment in appropriate cases, including the decriminalization of drug possession for personal use. Another example is the increasing use of the death penalty for drug offences. As the European Union considers the death penalty as a human rights abuse, there are legal obstacles for our member states to share police intelligence or judicial intelligence with countries that use the death penalty for drugs offences. This ultimately hampers international cooperation for ongoing investigations. A third example is engagement with civil society, as we're doing today. In particular, organizations working in harm reduction and representing people who use drugs, as we have in this meeting. By engaging with you, law enforcement responses can be crafted that are more sensitive to social context, trust between the police and the populations they serve can be increased, and responses can avoid exacerbating social harms. Finally, from a purely medical perspective, it is important to note that while there are significant health-related risks associated with Captagon, as the draft report states, a majority of use is characterized by short-term, low-harm recreational consumption. This is not, of course, to downplay the health risks, but it is important to properly contextualize them. All of this calls for a strategic, humane, and evidence-based approach to addressing the phenomenon of Captagon trafficking that sets reasonable expectations about what can be achieved through law enforcement actions and anticipates possible negative unintended consequences. Turning back to today's meeting, what we're hoping to get out of the meeting, I think, is two things. One, a better understanding of the phenomenon of Captagon and methamphetamine trafficking, and particularly usage in the region, which will then feed into the finalization of the report that Caroline has been working on and which will be finalized in the coming months. So we're really looking forward to getting your views also from those online to better understand the various dimensions of this phenomenon. And two, we would like to have your views in regard to recommendations, which is an important part of the report. And those recommendations can refer to harm reduction, supply reduction, law enforcement, demand reduction, or in fact any other topics that you think could be relevant for responding in a balanced and humane fashion to this phenomenon. Today's meeting should be We hope relatively informal, interactive. We're really looking forward to having an interactive conversation. And I would also note that it is under the Chatham House rule. So anything that is said today will not be attributed to the people who have said it. It will be reflected anonymously. So please do feel free to speak your minds. So that's all from me, but looking forward to the conversations today and to learning more about this topic from your perspective.
Good morning, everyone. It is now my pleasure to make brief opening remarks on behalf of the European Union Drugs Agency, which is based in Lisbon, Portugal, and in general, and on behalf of the EU for Monitoring Drugs project in particular. My name is Anne Bergenstrom, and I work as a health analyst in the EU for Monitoring Drugs project, which is one of EUDA's international technical cooperation projects. It started in 2019, and we basically support health and security-related activities in 13 countries of the European Neighbourhood Policy area. With me is my colleague Klaidas Kuchalskis, who has been in partnership with EU Act, organizing the meetings yesterday and day before. So that's about the project. Today's side event is being organized jointly by EU Act, MENA, and EUDA. I would like to commend EU Act for leadership and Maria's vision. It's been a joint effort. However, I do believe that we wouldn't be in this room today with the civil society organizations without Maria's vision. Yes, so thank you, Maria, for that. The focus of the meeting today will be on Captagon and methamphetamine. And we do understand that we need to collectively look at the situation on the ground and hear from civil society organizations, the people who are affected, and also technical experts, so that the situation can be better addressed. This year marks the 30th year when the European Drug Report has been published. It was published last month. The report shows that drug markets in Europe and in the neighboring area and globally continue to evolve. In order to better able to respond effectively to the many challenges posed by the evolving drug markets, we need to understand both the availability of different illicit substances on the market, patterns of use, extent of use, associated harms, and the broader impacts on the individuals, families, and communities at large. At the EUDA, the European Union Drugs Agency, we consider that health and security are interconnected. There can be no health without security and no security without health. The European Union drug strategy takes an evidence-based, integrated, and balanced multidisciplinary approach to the drugs phenomena at national, EU, and international levels. The drug strategy aims to protect and improve the well-being of society and of the individual, and to protect and promote public health, to offer higher levels of security and well-being at large, and to increase health literacy. It also incorporates gender equality and health equality perspectives. Just a few words about the drug supply, which was covered in detail in the last couple of days. The evolving and greater diversity of drug supply creates new challenges for prevention, treatment, harm reduction, and rehabilitation. Polysubstance use remains and continues to be an increasing concern, and we will hear a little bit about the polysubstance use in Tunisia today. And we would be interested to hear from all of you about the situation of polysubstance use in your countries. Increasing availability of and use of synthetic opioids, very potent substances, Stimulants and new psychoactive substances means that the existing services, such as harm reduction services, need to evolve and be able to adapt to reach out to people who are using substances other than opioids or heroin, for which the harm reduction services were a long time ago established for. So now there are new user groups who are using either multiple substances or new synthetic opioid stimulants, and these individuals may not readily relate to the harm reduction services that are available on the ground and that are used by, let's say, heroin injectors in the past. Last year, in July the 2nd, the EMCDDA, the European Monitoring Center for Drugs and Drug Addiction, became the European Union Drugs Agency. We have a new legal regulation, and within the legal regulation, cooperation with civil society is one of the new areas of work. I looked at the regulation yesterday and I searched for civil society, and it came up 20 times. And I can guarantee to you that that was not the case in the previous legal regulation of the EMCDDA, which goes back a few decades, because we have 30 years of existence now. So cooperation with civil society will be strengthened from here onwards. And if you are interested to know what exactly is in the regulation, it is on our website. And of course, civil society cooperation is highly reflected also in the European drug strategy. So this is one of the many areas of work, but I would like to draw your attention that this is it's like a new beginning. And so EUDA is building and developing a network of civil society organizations. There are other colleagues who are leading on that. And what I look forward to is to hear in the perspectives of civil society organizations and experts here today, and bringing back to the EUDA the key highlights, recommendations, and the key discussion points, so that we can consider them when we embark on planning of activities to be supported in 26 and beyond. The EU4MD project continues for another 2.5 years, the current phase, and we hope that there will be continuation beyond that. And we really support, we have activities that we support in countries including Morocco, Algeria, Tunisia, Libya, in the Northern Africa region. And cooperation with government of Egypt is currently under consideration and discussion. And in the Middle East, we work with Lebanon, Jordan, and Palestinian Authority, and also Israel. And as you can imagine, it's a challenging geopolitical situation in the region. We also work with countries in the Eastern European neighborhood area, including candidate countries to the EU, Ukraine, Moldova, and Georgia, and 2 other countries. But all of these recommendations that you have today, I will listen carefully, and I will make sure that we will reflect them in our mission report, and I will be briefing along with Glydas, our colleagues in Lisbon, well, headquarters, where we are based. So thank you very much on your behalf for taking your time, on behalf of EUDA for taking your time, and look forward to the discussions today. And I'll hand over to Eli for his opening remarks.
Thank you. Good morning. My name is Eli Araj. I'm the Executive Director of the Middle East and North Africa Harm Reduction Association based in Beirut. And I'm glad to be here with you, thanks to EUDA and to EU Act. I want to say that MENA is honored to continue the collaboration with EUDA and glad to start the partnership with EU Act. Our partnership started years ago, trying to understand the common space of concerns in the fight against the drug addiction epidemic. This event comes at a very critical turmoil in our region, where we are witnessing increase of violence, racism, and the rise of new synthetic and fatal drugs. The drug problem has been treated only from a law enforcement and legal perspectives. Drug policy followed the Nixon's slogan, "Say no to drugs, war on drugs," which becomes a war against people who use drugs. This side event, back to a two-day consultation meeting with law enforcement officers and diplomatic delegation with the Ministers of Interior Affairs at the League of Arab States, aims at giving the CSO a space to show their concerns and contribute to leverage human rights and public health component and to influence the drug policy reform in the countries of our region. We are living in a situation of emerging new trends of drug use in the region and the Mediterranean neighborhood. I would like to stop here to thank you because I will have time for another presentation, and I hope to have helpful and fruitful workshop. Thank you.
Thank you. Normally now, Maria would say a few words as the director of EU Act, but she's managing a couple of different emergencies. So I suggest that we go directly to Caroline for her presentation, and maybe Maria can come in later.
Great. Hello, everyone. It's wonderful to be here. My name is Caroline Rose, and I'm a consultant for the EUDA and EU Act. We are putting together a report based on responses that different countries across the region regarding Captagon and methamphetamine distribution, consumption, and production. And so I'm going to review some of the findings as well as the recommendations of the initial draft report. But as some of my colleagues have mentioned, this report will be finalized towards the end of the year. So of course, this is a work in progress, and I very much look forward to hearing some of the feedback and responses and observations that everyone here has had in the region. So we'll start first. Can we go to the next slide, please? Thanks so much. So I'll first start with the introduction and methodology of how this report was put together. Thank you so much. So in the last 10 years, we've seen a major proliferation of amphetamine-type stimulants like Captagon and methamphetamine along the southern route and in North Africa. This report very much assesses how that has come to be, looking at the production, trafficking, and consumption patterns within the region. It identifies a series of patterns as well as informational and intelligence gaps, both about production, trafficking, and consumption, as well as offers detailed interventions and policy recommendations for how regional players, both state actors and non-state actors, can work together to confront this emerging challenge. It disseminated a strategic assessment. The EU Act disseminated this questionnaire at the end of 2024 that asked countries to submit data between the years 2020 and 2024 about consumption, production, and trafficking patterns that they have observed. 11 countries total submitted answers detailing either available or lack of available data related to both Captagon and methamphetamine. You can see that Algeria, Egypt, Iraq, Jordan, Lebanon, Libya, Morocco, Pakistan, Palestine, Tunisia, and Turkey all submitted data. And I think it's important to note that amongst these different countries, sorry, the microphone has a little bit of feedback, so I'm going to move it a little further away. Amongst these countries, there were different levels of data that was submitted. Some countries had a lot to say, some countries did not, and we'll review some of those data and informational gaps.
Sorry for the interpretation on that one.
Excellent. Complementing some of the data that was submitted by countries, additionally,
واستكمالا لتحليل إجابات
open source analysis, looking at available literature, such as, for example, a report that MENA commissioned on Captagon and methamphetamine in synthetic production in the region, as well as academic literature, media reports that tries to fill in some of these data gaps, and we'll review some of them in the next few slides. Next slide, please. We'll start off with the Captagon trade first. Next slide. So just a review of Captagon. Since the early 2000s, Captagon has been on the steady rise in the Middle East and North Africa, with a particular surge in the last 5 years. And the Levant, of course, has been one of the regions where Captagon. Between the 1960s and mid-1980s. Then, of course, afterwards, it was scheduled by the World Health Organization and became an illicit substance that was traded within illicit economies. Over time, there have been signs of small-scale production outside of Syria. Especially, this has been the case after the fall of the Assad regime at the end of December, the beginning of December in 2024. Traditionally, Syria has been an anchor for large-scale Captagon production, and we've seen a lot of, I'm sure many here have seen those labs and the footage that came out from Syria after there was the revolution in Syria. And while there's been major disruption to these industrial-scale Captagon manufacturing sites, this doesn't mean that Captagon is no longer a problem in the region. This instead, and the report assesses that this means that small-scale Captagon production is likely spilling out from Syria into destination markets and consumer markets, identifying new modes of operation. White pill of Captagon, which is commonly referred to as the Lexus variant, includes a very high concentration of amphetamine and very few cutting agents and other additional chemical additives, whereas other brands or colors of Captagon, light yellow Captagon pills, light beige, purple or pink, dark brown or gray pills, have very different chemical components that are included. So many that I know it's sometimes difficult to see some of the terms on this graph. But you can see that the different colors vary drastically, which show that a lot of Captagon producers, they are inventing new ways, constantly trying to identify new methods of production and new chemicals that they can put inside of a Captagon tablet. Unfortunately, there's very little laboratory analysis that is publicly available. And of course, I think many here can confirm that this information is crucial to understand the public health harms and the risks that are in place for Captagon consumption. This particular laboratory analysis, we were able to get this data because of collaboration between the Jordanian Anti-Narcotics Directorate and the German police. And Germany has an excellent lab where they can conduct this data, they can conduct laboratory analyses and compare it with previous data that has been collected on Captagon and other amphetamine-type stimulants. And so as a result, we were able to see not only test results for a certain seizure of Captagon, but all the different colors and different brands, so to speak, for Captagon tablets. There have been laboratory seizures conducted in Syria, many of which that were conducted at the end of 2024 and throughout 2025. But that being said, there is a lack of routine evidence about Captagon's formulaic composition. And as a result, that is a key informational gap. We are very much flying blind when it comes to understanding the chemical composition and consistent chemical composition and evolution of Captagon's formula. Next slide, please. I'll move on to trafficking hubs, and this is an interesting graph because there was a question within the strategic assessment that asked countries to self-identify and declare a status when it comes to the Captagon trade. You can see that amongst the 11 countries that submitted data, 7 confirmed seizing Captagon in the last 4 years. And when it comes to identifying a status, 6 out of the 11 countries identified as a transit country. Only Iraq identified a dual status as both an origin and transit country for Captagon. We've seen quite a few labs that have been seized in both southern and northern Iraq over the last 3 years. Now, when you look into the open source, and there are a few databases that we've been able to use, as well as public media reports of seizures. And when you look at the data comprehensively, you can find 25 countries total that have interacted with the Captagon trade with some shape or form, whether through seizures or lab interdictions. And that list comprises a much larger list than reflected in the strategic assessment responses, because there's only 11 countries from the region that participated. But that larger list includes Austria, Egypt, Germany, Greece, Iraq, Italy, Jordan, Kuwait, Lebanon, Malaysia, Morocco, Nigeria, the Netherlands, Oman, Palestine, Qatar, Romania, Saudi Arabia, Syria, Sudan, and Turkey, and the UAE, Libya, Venezuela, and Yemen. And I think that list shows, while of course Captagon is very much anchored in the Middle East and North Africa, this is becoming a more trans-regional industry, and it is touching countries that are well outside of the region, even if they are just transit sites. But Captagon has had an effect well outside of the region, and that's something certainly to be monitored. Next slide, please. Now, I think that this is perhaps one of the most important graphics when it comes to some of the information gaps that we have. The strategic assessment inquired with submitting countries whether they had available information about Captagon consumption, whether that is just the level of use or even patterns of usage. And you can see that only 27.3% confirmed that they had consumption data available. 72.7% confirmed that they did not. And so despite the fact that Captagon has become so widely distributed throughout the region, it's very clear that there is a huge blind spot when it comes to Captagon consumption, knowing the reasons why many are drawn to using Captagon, how they use it, the different patterns of use and other characteristics. So Captagon's profile of usage, as I think many here know, is very complex from what we've been able to glean through open source information. It transcends just pure recreation. There are many users that use Captagon for food insecurity, for example, to stave meals, sometimes income insecurity, especially those that are working multiple shifts. They will sometimes use Captagon to, for example, get through a night shift, or if you are a taxi or truck driver, they will use it to try and get them through a long night of driving. Captagon helps sustain your attention, so university students are drawn to Captagon to help them get through exams and long nights of studying. And then also Captagon, of course, has been affiliated with the staving trauma, inducing a euphoric-like effect sometimes amongst users, or sometimes aiding fighters in battlefield performance. And we've seen that very much be the case in both Syria as well as across the region, especially as we've seen an increase in conflict. Next slide, please.
Can you put closer to the mic? Caro, closer to the mic.
Oh, sure. Now, with Captagon treatment, there are a variety of different risks that we have identified within the strategic assessment. With long-term use, Captagon consumption can sometimes induce a range of symptoms, such as hypertension, psychosis, and of course, some very serious withdrawal symptoms. That being said, we don't want to characterize all Captagon usage as long-term and extremely dangerous, as the majority of use has been characterized by short-term, low-harm, and recreational consumption. That being said, it is highly addictive. And as you have seen in some of the previous slides, we don't necessarily always know what is within a Captagon pill, especially if there are new brands that have emerged. Rehabilitation pathways for Captagon dependency has proved extremely challenging for regional actors, and limited treatment pathways have had little accessibility in the region. We've heard many stories about Captagon dependent individuals that have sought treatment well outside of their country and well outside of the region, such as on Harley Street in London in the United Kingdom, or at rehabilitation centers in Switzerland. And so that is very much reflective of a lack of pathways for treatment and rehabilitation in the region. Next slide, please. And I wanted to show this slide regarding some of the data that we were able to glean on prices. As you can see, only 3 countries had available data on Captagon pricing. So this is a major informational gap. And this is, I think, especially important now that we are potentially perceiving and seeing a shortage of Captagon supply after the fall of the Assad regime in Syria. So I think that these prices are very much going to fluctuate as new producers try and fill in this gap, and consumers seek out different substances. But it's very clear that Captagon's cheap prices have made the substance highly accessible and very competitive compared to other substances, even alcohol. And as you can see, 54.5% of respondents indicated they don't have information about wholesale or retail pricing. So this is, I think, another area where civil society organizations could potentially step in and try and exchange information about what they're seeing with pricing. And we'll move on to the methamphetamine section. So there are 3 different geopolitical developments that have imposed major effects to the proliferation and production and trafficking and consumption of methamphetamine.
Sorry.
Yeah, no worries.
I got lost. It's here or?
Yes, this is perfect.
Sorry.
Thanks so much. We have 3 different developments. Of course, number 1, it's been the Taliban's ban of poppy cultivation and heroin production and methamphetamine production in Afghanistan. This has resulted in what we think has been a surge in methamphetamine flows from the region, as well as a change in how methamphetamine, synthetic drugs and heroin have been distributed throughout the region. Of course, also the collapse of the Assad regime in Syria. This has changed some of the routes. Many traditional methamphetamine routes in the region have been through Syria. So the disruption of that trade and the imposition of a new administration there has also potentially shifted some of these routes. And then number 3, the effects of Israel's military campaigns across the region and regional escalation between Iran and Israel. This is another factor that we think also has a potential to change routes and how traffickers have operated. Next slide, please. You can see here that with countries that have reported methamphetamine seizures in the last 4 years, the region is overwhelmingly affected by the proliferation of methamphetamine. 81.8% confirmed that they have conducted a seizure of methamphetamine, whether it is in crystal form, powder form, liquid form, tablet form. And so you can see that an overwhelming majority has been affected. Looking to open source analyses, and there's also a database on Captagon that we've been able to set up. You can see that there is also a larger list that transcends just that list of 11 countries that participated. You have Egypt, Jordan, Kuwait, Oman, Qatar, the UAE, Yemen, Iraq, Bahrain, Turkey, Saudi Arabia, Egypt, Lebanon, and Syria, all countries that have conducted methamphetamine interdictions over this 4-year period. Next slide, please. And when it comes to consumption data, it's very clear that countries in the region have more intelligence and informational availability about consumption of methamphetamine than compared to Captagon. You can see that 63.6% confirmed that they had data. So that's just over half of respondents. In a recent report, actually, and something I wanted to raise, that MENA conducted, they also identified a larger list of countries that also experienced a proliferation of methamphetamine and synthetic stimulants. Bahrain, Iran, Iraq, Jordan, Kuwait, Oman, Palestine, Qatar, and Yemen have all engaged with the proliferation of methamphetamines and amphetamines. Next slide. And I will say, this one graph, it says kilograms. This is actually per gram. So there is a mistake on this one graph that, of course, we're going to correct in the final report. But just to give you a picture of prices, you can see that pricing is extremely low the closer you get to production hubs. And in Iraq and Jordan, the prices of on the street level of 1 gram of methamphetamine per euro, it's much higher. Some countries, they only were able to offer either the minimum wholesale or import price. Some countries were only able to offer the average. So there are a few data gaps that you can glean from this graph. It's notable that Pakistan's average price was 1,640% lower than Jordan's, and 1,240% lower than Iraq. So you can see a very large fluctuation in pricing when it comes to methamphetamine. Next slide, please. Now, when it comes to policy actions, the strategic assessment and the report identify a series of informational gaps, as well as areas that many states want to try and improve upon when it comes to consumption data, interdictions, approaching harm reduction and demand reduction strategies. And so we'll review some of these. Next slide, please. It's very clear that many national programs, the few that have been established, they have placed a central focus on enhancing interdiction capacity through the acquisition of new technologies like night goggles and intelligence and reconnaissance collection techniques. But this comprises a very interdiction-heavy approach. The strategic assessment does identify very few national strategies that incorporate an approach to harm reduction and demand reduction. Also, of course, strategies that don't have the capacity to identify consumption patterns. So this is certainly an imbalance that is noted in the policy gaps and the informational gaps within the assessment. With the spread of amphetamine-type stimulants, and there's certainly been an increased attention in programming, but still there are key gaps in countries' law enforcement, security, legal, and health sectors to sufficiently respond to respective challenges. And as Anne mentioned as well, with the proliferation of synthetics, with the constant evolution of how these drugs are made, it's very important for countries to constantly monitor and prepare themselves for this evolution. There are some existing mechanisms to counter the proliferation of Captagon and methamphetamine, but a lot of them are tucked into larger national or international initiatives where Captagon and methamphetamine sometimes is just a passing phrase rather than a dedicated working group or task force or mechanism that allows countries to share specific information, lessons learned, and best practices. With a prominent rise in MPS like Captagon and methamphetamine and other drugs, there is an urgent need for an enhanced counter-narcotics policy, targeted interventions, and also importantly, harm and demand reduction measures. So this is, I think, a great segue into our next slide on policy recommendations. So broadly, we have a few different recommendations. Number one is to improve intelligence collection and investigation techniques, to carry out more consistent forensic analysis of seized pills to understand the health risks and other challenges to public health, improve detection technologies and capabilities, understand how these criminal actors are operating in the trade, encourage countries to adopt a more balanced focus between demand and supply reduction, especially trying to increase focus on demand reduction strategies and harm reduction strategies, initiating a region-wide strategy and a mechanism to collaboratively counter illicit drugs, specifically Captagon and methamphetamine, and then importantly, reducing the informational gap on consumption, trying to work with either civil society organizations, universities, actors that are active in this space that have the ability to conduct research, surveys, and gather information on how Captagon and methamphetamine is being actively consumed. And I'll leave it there. I know that we'll have a lot to discuss about the findings and also how we can fill in some of these informational gaps. But thank you so much for your attention, and I appreciate it.
Thank you very much, Caroline. And this is what multitasking has. I'm not going to say opening remarks because everything has been said already. I'm just going to thank everybody for being here today. As Anne said, I really wanted to hear the other side of the story. And I myself, as Ellie knows, I lived in Lebanon for a long time, and I always like to listen to both sides because I think the only way to get the full picture is by hearing both sides of the story. So really grateful and thankful that you all came from far for just a 24-hour meeting. But your input will be essential in order to shape not only the report, but also the possible responses that we will develop in the region. And just wanted to run you a bit through the day. And I also have some logistic questions that I have to ask that are as always important. So after this, we will have the presentation of Lebanon, and I think Schoon is online, correct? Yes. Sorry, first MENA, and then Schoon is online, Jordan is here, Iraq is here. Iraq is here? Yes, Iraq is here. I believe that unfortunately we will not have the presentation of Syria because of the current circumstances makes it very, very difficult, but it's also an actor that we would like to hear more. And this is also a call for, if you know organizations that are not here, but that can have relevant input throughout whatever is left of the program, and I'm sure you all know organizations that are working in similar issues, please connect them through Ellie with us or connect them directly through us, whatever is easier, because we want to make sure that we hear those sides of the story when we take on board this report. Then I think the floor is for Ellie, and thank you very much, Ellie, for being here.
Hello again, and really honored to be with you, and glad for this. And I don't think this topic will be ending at the end of the day. I think with the recommendations that we will have, we will go further for some more collaboration and implementation in the future. Caroline Thank you for your presentation. I think we used the same references because this is alarming because of the scarcity of information in the region. So that's why you might see something that you saw with Caroline's presentation. I'm sorry if, for the redundancy. Anna?
Yes.
So I'll try to give a regional overview of the state and impact and prospects of Captagon and methamphetamine in the region that was prepared by MENA. And here, allow me to thank my dear colleague, Isabel Salemi. She is a program coordinator who supported me in the preparation of this presentation. And I will speak in Arabic, surprise.
Just 1 second, Ellie.
Yes, waiting for the presentation.
Yeah, 1 second. It's in here, Ellie PPT. Yeah.
Okay, I can start by something that is not interested. It's interesting, very interesting. So we'll give you an introduction about MENA, and then we'll go for the main drugs used, Captagon, etc., country-specific data, and we will finish by some recommendations. فإذا MENA ابتدت MENA بال 2007 سنة 2007 بمبادرة من منظمة الصحة العالمية والجمعية الدولية للحد من المخاطر استخدام المخدرات HRI، وطبعا صارت مسجلة بلبنان كمنظمة دولية غير حكومية لا تبغي الربح من 2012. الرسالة تبعيتنا أو الميشن هي لإطالة ما في ترجمة؟
نعم تفضل أستاذ. Can you hear me? Is there a problem? So, our main mission or task is to extend and develop the quality of life of people consuming drugs by reducing the risks of drug consumption, as well as strengthening the capacities of civil society organizations to be able to implement such programs and projects.
بالنسبة للوضع بالمنطقة كلنا بنعرف إنه في مشاكل كبيرة، وفي يعني المستوى الأمني على المستوى الأمني والحروب التي نمر بها من فترة. المشاكل تخطت سوريا، لبنان، فلسطين، اليمن، العراق، وهيدا ساهم بإنه يضعف الإدارة والخدمات الصحية والنظام الصحي بهذه الدول. هناك بالمنطقة ملايين المهاجرين والمهجرين، وبالتالي يعني هي يمكن أعلى منطقة بالعالم حيث يوجد ناس خارج بيوتهم وخارج إطار منازلهم ومحيطهم الطبيعي، كمان ما عم بيقدروا يحصلوا على الخدمات الأساسية حتى. هيدا أثر على يعني الصحة العامة، وبالتالي رفع مستوى التحديات اللي مرتبطة باستخدام المخدرات وبالتقاط عدوى ال HIV. إنه انكسار الخدمات والبنى التحتية كمان ساهم بازدياد مستوى الهشاشة vulnerability عند الناس. تجارة المخدرات كمان يعني استفادت من هذه الهشاشة عند المجتمعات، وأيضا ساهمت بأنه يكون في إنتاج وتجارة خاصة الكابتاجون والمواد الأفيونية وغيرها من المواد. وهناك أيضا صار في حصول ووصول إلى المخدرات بشكل سريع وضعيف، يعني غير مكلف لنقول عند الفئات المهمشة. هذا رفع مستوى الخطر بالتقاط ال HIV، وفي هناك خدمات very limited كتير يعني محصورة للحد من المخاطر، بالإضافة ل يعني القوانين المجرمة اللي بتساهم كل هذا المخاطر عند الاشخاص بيستخدموا مخدرات والفئات الاخرى مثل الرجال الذين يمارسون الجنس مع الرجال والمفتاحيات والفئات المفتاحيه الاخرى. الملخص هو انه يعني عدم الاستقرار السياسي والمشاكل الامنيه عم بيغذوا الكرايسيس، المشكله تبع الصحه العامه، وبالتالي عم بيخلوا انه يكون في هناك حاجه ل يعني عمل سريع وواسع من الحد من المخاطر بخلال المنطقه كلها. بالمنطقه فينا نشوف انه في يعني صعود رهيب للسنتيتيك دراج، للمخدرات الاصطناعيه، انتشار وازدياد الانتاج للكابتاجون بسوريا خاصه ساهم يعني انه يغذي الدول الاخرى عن طريق تجاره من خلال العراق، الاردن، ووصولا الى الخليج، ساهم بانه يغذي الدول بانه يكون في استخدام اكثر لهالماده هذه. الميثامفيتامين بالمنطقه عندنا بسموه الشابو، بينلفظ بلغه بطريقتين او بينكتب بطريقتين. بالامارات يعني سجلوا اكثر نسبه ارتفاع ل يعني الضبطيات، الكونفiscations على مستوى المنطقه، اللي هي 50% من ضبطيات المخدرات بالامارات كانت مرتبطه بموضوع الميثامفيتامين. فينا نقول انه هناك ايضا مواد اخرى تستخدم مثل الكنابس يلي هو الحشيش، عندنا معروف حشيش او ماريجوانا يلي واسع انتشاره واستخدامه، بيلحقوا الاوبيويدز الافيونيات، وايضا المشاكل المرتبطه باستخدام الادويه بشكل غير قانوني. الحقن بالمخدرات We are at the MENA region overview evolving drug use trend. Again, yes. No, again, one again. This one. Thank you. Yeah. I'm sorry, I'm not used to. Okay, so بالنسبه للحقن المرتبط بالمخدرات في يعني تقدير بانه عندنا 320,000 مستخدم عن طريق الحقن بالمنطقه، ويعني هن عم بيعانوا من مخاطر كثيره مرتبطه بالسلوكيات، في مشاركه بالحقن، وفي يعني حالات جرعه زائده كثيره. المشكله انه الجرعه الزائده لا تسجل بسبب القوانين القمعيه، لهالسبب يعني عم بيصير في اوقات حالات وفيات لا تعلن بس انها بسبب جرعه زائده، ولكن يقال انه كريزه قلب او حاجه زي كده. في نقص بالخدمات الحد من المخاطر، لا يوجد وصول يعني بسيط لمستخدمي المخدرات لهالخدمات، منهم الحقن والمحاقن، منهم النالوكسون الوقايه من الجرعه الزائده، وايضا خدمات الاتش اي في من التست يعني الفحص لخدمات البريب والبيب ايضا. Next. I don't know. I told her. Yes, no, estimated, yeah. فاذا هيدا التقرير بيفرجي شوي قد ايه في عندنا اشخاص بيستخدموا مخدرات عن طريق الحقن بالمنطقه. بنشوف انه في ارقام مرتفعه ببعض الدول، باكستان مثلا 430,000، بفلسطين 5000، قطر 1827، سعودي ارابيا 3400، 10,000 بسوريا، 11,000 بتونس، 9,000 بلبنان، 10,488 بالاردن. هيدول كلهم حتى العراق يعني رقم كبير 39,277، بإيران 138,000 وشوي، بمصر 96,000. هدول تقريبا آخر population size estimate انعملوا بالمنطقة، ولكن القصة إنه ما بنشوف بكل الدول يعني تقرير عن هذا الموضوع بسبب عدم رغبة سياسية بإنه نواجه هذه المشكلة بشكل صحيح. Next. أكثر أنواع مخدرات مستخدمة أو next أنا بليز. فاذا اكثر انواع مخدرات مستخدمه او انجكتد، فينا نشوف بهذا التقرير كيف اذا بنشوف اللي قبله ما راح نشوف كثير ميثامفيتامين ولا راح نشوف كابتاجون. بهذا التقرير عم نشوف استخدام الميثامفيتامين، وايضا الناس اللي عم يتوجهوا للعلاج باخر كولوم عم يتوجهوا للعلاج من اجل ميثامفيتامين. بقدر اقول انه يمكن الحشيش اني اذر كان اي نوع اخر من المخدرات كنا نشوفها بالتقارير السابقه، ولكن اليوم صرنا عم نشوف الامفيتامين او الميثامفيتامين موجود بهيدي يعني السلوكيات، وعم بيصير في مشاكل لانه عم تطلع اكثر بالدول وعم بتبين اكثر واكثر. كمان I will share this report with you of course. بنشوف كمان حتى يعني الدول يلي يمكن ما بتصرح بعد، مثلا مثل الأردن، مثل بعض الدول الأخرى، عمان، في حاجة كبيرة لأنه نرجع نكتشف أكثر شو عم بيصير عندهم من هذه السلوكيات وسواها. مثل هون باكستان، قطر، فلسطين، مع انه بيقولوا انه عندهم استخدام للكابتاجون، واكيد كلنا بنعرف انه في استخدام للكابتاجون. قطر نفس الشيء. بس بالسعوديه في عندهم اشخاص بالعلاج على الميثامفيتامين وسواها، ولكن لا يسجلوا اي عدد او اي رقم بالنسبه للاستخدام. كمان اليمن، الامارات وسوريا طبعا نعرف انه في استخدام، ولكن ما بنعرف اذا عم يتبعوا او لا. next next and next and another next. فاذا هلا رح نحكي شوي بالتحديد عن الكابتاجون والميثامفيتامين بالمنطقه. فينا نشوف انه بالسعوديه عندهم يعني اكثر نسبه ضبطيات. بنشوف انه او بالاحرى الترافيكينج، التجاره والتهريب. وهيدا التقارير بين 2010 وال 2021 نحن راح نشوف انه الاكثر نسبه عم بتبين هي من بعد 2011 و12، ومركزه اكثر من بعد 2016 على الضبطيات بهذه الدول. فينا نشوف انه يعني بلبنان في كميه صغيره، بالكويت في كميه شوي اكبر، سوريا طبعا يعني ما بينحكى، ولكن لانه يمكن هو ما في تقارير كانت بخلال فتره الثوره يعني وما بعدها. وراح نلاحظ انه بسوريا قبل ما كان في حتى يعني شيء بيقول انه في مخدرات، مع انه يعني انا شخصيا ساهمت مع UNAIDS و WHO سنه 2006 ب بايو بيهيفيرال ستدي بدمشق وريف دمشق، وكان في عندنا حالات يعني واضحه. هون الضبطيات يلي عم نشوف انه دايناميك كيفيه يعني من افغانستان للدول العربيه الاخرى. السعوديه بتسجل رقم كبير. next please. I'm sorry. next. yes. هذه الماب اللي بتفرجي مثل ما قلنا التجاره، خاصه لما بنشوف انه العراق عم بيكون بفتره معينه بلد مرور، واللي عم بيصير شوي شوي بلد يعني استخدام متوطن فيه الميثامفيتامين والكابتاجون على هذا المستوى. طبعا افغانستان وايران حدث ولا حرج، ولبنان ايضا يعني بشكل او باخر كان له دور بالعبور، ولكن ايضا بالاستخدام. بمصر الاسبوع الماضي كنت بمصر، وكانوا عم بيعبروا كثير عن انه عم يرجع يطلع عندهم حالات جديده من الميثامفيتامين والكابتاجون. مثل ما قلت لكم قبل شوي يعني طلعت الضبطيات اكثر بين 2016 وال 2020، وصولا لانها توصل لارقام عاليه بهذه الفتره. نكست. رح نفوت بالتفصيل بكل بلد. نكست. افغانستان هي يعني البلد معروف انه اكثر يعني هو الليدر تبع انتاج المواد الافيونيه واللي عم بيتغذى يعني الاندستري تبعته اكثر من مالتي بليون دولار بمليارات الدولارات. طالبان عملت بان وجربت انه تكفي بهذا الموضوع، بس ما كثير اشتغل، لانه كمان راح على انتاج اشياء ثانيه. الميث برودكشن، الانتاج تبع الميث هو الكريستال ميث بيضلوا قوي برغم البانينج يعني المنع، وغيرها من المواد اللي بتقدر توصل لانه تكون عم توصل للناس باسعار متدنيه. نيكست. بحرين. الكابتاجون والميثامفيتامين هن المسيطرين بالسينثيتيك دراج ماركت، بالسوق يعني المواد الاصطناعيه المستخدمه بالبحرين. الكابتاجون هو اكثر شيء موجود بين سائقي الشاحنات بالنسبه لهم ليضلوا صاحيين، وبين النساء بالنسبه لهم ليخفضوا الوزن. الميثامفيتامين خاصه متواجد بين الفئات الشبابيه، وهن بيوصلوا لهم عن طريق يعني جنوب شرق اسيا وافغانستان. ما عندنا داتا على الوضع الديموغرافي للاشخاص بيستخدموا المواد الاصطناعيه. نيكست. مصر. مثل ما قلنا في يعني ارتفاع باستخدام المواد المصنعه، المخدرات المصنعه بكامل البلد. في كثير استخدام للترامادول بمصر اللي بيجي عن طريق ليبيا وعن طريق البحر. الكابتاجون بيجي من لبنان ومن سوريا، والميثامفيتامين بيجوا عن طريق افغانستان. نيكست. ايران نعرف انه الهيروين والافيونيات هن اكثر شيء بيستخدموا عن طريق الحقن بايران. هن يعني المركز الاساسي للتجاره والتهريب بالهيروين مع اسعار منخفضه. باخر 2023 نزلت الترافيكينج بايران، لانه يبدو انه التجار قرروا انهم يروحوا يوجهوها لبرا لياخذوا اسعار اعلى، وبالتالي ارتفع السعر بايران كمان. طلع كثير استخدام بايران. عندهم يعني حاله خاصه، هن عم بيجربوا كانوا من كذا سنه يعملوا علاج بديل عن طريق الاوبيوم تانكتشر. صار في ارتفاع باستخدام الاوبيوم تانكتشر بشكل غير رسمي، مش متابع يعني من قبل الاطباء والمعنيين. بغير هيك بايران بنشوف استخدام الحشيش، وهناك طبعا في انتاج محلي، يعني في ناس عم يزرعوا حد البيت او بقلب الحديقه بالباك يارد، وفي يعني استيراد من افغانستان. الميثامفيتامين، انتاج الميثامفيتامين وسواها كمان عم بينتشر. الاتش اي في، مخاطر الاتش اي في ومخاطر السلوكيات هي الاستخدام عن طريق الحقن. طبعا مثل ما بنعرف في اشياء مرتبطه، احيانا بيعملوا علاقات جنسيه كرمال يحصلوا على المخدرات. الميثامفيتامين والكوكايين مرتبطين كثير بعده شو بيقولوا بارتنرز جنسيين، شركاء جنسيين. وهناك يعني ارتفاع بالاتش اي في ريليتد بيهيفير اللي هو السلوكيات المعرضه للاتش اي في. نيكست. العراق بين 2019 و 2023 ابتدى يصير واضح استخدام الميثامفيتامين والكابتاجون والتجاره من خلال عن طريق العراق. في ضبطيات كانت في ضبطيات كانت يعني حوالي 3.380%، منهم 4 طن وشوي انضبطوا بال 2023. increased 6% 6 مرات اكثر بخلال هذه الفتره. عم بينطلب مني اني اوقف بس اقول لكم انه بس بالشارع الميثامفيتامين الجرام ب $11.5 ل $19 والكابتاجون الحبه ب $2. بالاردن الاستخدام عم بيكون بين الكابتاجون كانابينويد الكحول بنزوديازيبين وكريستال ميت، بس في استخدام لمواد اخرى والكابتاجون زاد بشكل كثير. 21% من المرضى بالتريتمنت سنترز عم بيكونوا من استخدام الكابتاجون. لبنان بنشوف انه بعده الكنابيس هو اكثر شيء، ولكن انا فيني اقول لكم عن لبنان انه السنه نحن بالسيرانج اناليسيس مع اليو دي اي بعد ما نشرت الريبورت، ولكن طلع عندنا الميثامفيتامين انجكتنج ميثامفيتامين هو اول استخدام بلبنان. ما بعرف بلال انت بتقلنا عن تونس. المغرب معروف اكثر شيء استخدام نكست موروكو. استخدام الكنابيس وانتاج الكنابيس هو من اكبر الدول بالعالم، وايضا عم بيكون في مواد اخرى اصطناعيه بسموها كركوبي يلي هي سينثيتيك دراجز مع سولفنت مع بنزوديازيبين، وايضا هيدي سعرها كثير متدني. بعمان عم نحكي عن السينثيتيك دراجز كمان بالتجاره، وخاصه انه في طلب عليها بين الشباب، وعم نحكي كمان انه الكابتاجون تحول لمشروع انتاجي، يعني سوق منتج بالنسبه لعمان. باكستان الميثامفيتامين 52.5% بالاستخدام. بفلسطين اذا بدنا نطلع بنشوف انه كمان هون متدني شوي، ولكن نرجع بنحكي انه الاعمار تدنى، عم نحكي عن اعمار 13 سنه وما فوق بخاصه الضفه. بالامارات كان عندهم كثير حالات ضبطيه لاشخاص عم يستخدموا مخدرات. بنشوف انه بالامفيتامين عم يستخدموه خاصه الكابتاجون موجود، كريستال ميت وسينثيتيك كانابينويد and prescription meds في منهم ترامادول وبريجابالين عم يطلعوا. امفيتامين اكثر شيء عم يستخدم بالإليسيت دراجز followed by ليريكا and ترامادول. سعودي ارابيا 40% من الاشخاص عندهم substance use disorder، وهناك حالات 34% من حالات الاستشفاء للعلاج هن من استخدام الامفيتامين وسواها. 48% من مراكز الادمان والعلاج هن عم بيحكوا انه الامفيتامين هو الاساسي بالاشخاص اللي عم بيجوا لعندهم، وهذا مرتبط ببعض السلوكيات العنفيه يعني اللي عم بيصير. الميثامفيتامين يوز از رايزنج، عم بيعلى بشكل سريع مع مثل ما قلنا حالات عنف وغيرها. سوريا كلنا بنعرف الوضع الاقتصادي، بنعرف المشاكل اللي عم بتصير عندهم. فينا نحكي عن انه تدني كمان الوضع الاقتصادي، هذا خلى انه يكون بفتره القصاصات السانكشنز على سوريا كان استفاد النظام وقتها من انه يستفيد من سوق المخدرات، وهذا خلى انه يطلع بشكل انه تصير سوريا معروفه وكأنها دوله منتجه او دوله المخدرات بشكل او باخر. واليوم عم نشوف انه الحكم الحالي عم بيحاول انه يخفف من هذا الشغل ويحارب. اليمن نعرف انه الحوثي هو ماسك اكثر نسبه من سوق المخدرات والتهريب، وبنشوف انه الميثامفيتامين والحشيش والهيروين مع انه كان القاط مقبول اجتماعيا 14% من الاراضي اليمنيه هي قابله للزرع مزروعه بالقاط وسواها، ولكن ايضا بنشوف انه في ارتفاع باستخدام الكابتاجون والبريسكريبشن دراج ابيوز. قطر، فاذا بقطر بنشوف انه الاعمار هي بين 20 و 29. 54% من الاشخاص اللي انعملوا بدراسه معينه سنه 2024 بينوا انهم ما بيشتغلوا. اكثر نسبه استخدام هي الميثامفيتامين 77.3%، بيلحقها الكنابيس، وبالباقي الامفيتامين 57.6%. أما بالنسبة لخدمات الحد من المخاطر next twice please again next بتلاحظوا انه ما في كثير خدمات harm reduction بالمنطقه حد من المخاطر بعدهم سابق الاخرين ولكن ما في التغطيه لا الجغرافيه ولا بالخدمات اللازمه للمنطقه next please next اوكي المجتمع المدني عم بيساهم بشغل له علاقه بالمناصره وال يعني والعمل على السياسات ويعني التعريف بحقوق الانسان. في عندنا ريجنال نتوركس تقريبا 3 بيشتغلوا بهذا المجال، وفي ايضا حاجه للشغل على ببعض الدول على بعض المواضيع يعني نركز عليهم، حتشوفوهم بالبرزنتيشن رح نعطيكم اياها. وهناك تحديات اساسيه اللي هي لها علاقه بالسياسات الموجوده، السياسات القمعيه والقانونيه بالتمويل لهي الخدمات وخاصه بالوصم والتمييز اللي نسبتهم مرتفعه. next هناك ببعض الدول عندنا مش بعضها كلها في السياسات قمعيه والقوانين قمعيه، ولكن في بعض الدول لازالت تعتمد يعني الديث بنالتي الحكم بالاعدام. في بعض الدول يعني تتعامل مع الموضوع بشكل متوسط والاخر لا. هناك توجه بانه نوصل لعدم تجريم ببعض الدول، وايضا الحفاظ على سريه الاشخاص، وهناك حاجه لدعم يعني السياسات ببعض الدول الاخرى. كمان في قصص لها علاقه باليمن اللي هي ثقافيا لازم يكون في شغل على الموضوع. اخر سلايد recommendations. في واضح صار انه في حاجات لنشتغل على الميثامفيتامين والكابتاجون يوز، بده يكون في عندنا نكتشف ان كان للديماند ريدكشن للحد من الاستخدام او للحد من المخاطر، لازم نشوف كيف فينا نعمل على هذا الموضوع. بالشق الاخر يلي يمكن نحن كسيفل سوسايتي ما قلنا عليها فيه، لازم ينشاف طرق التهريب اللي عم بتصير وكيفيه ضبطها. حاجه لارتفاع خدمات الحد من المخاطر بالنسبه لهالمواد الجديده، وايضا شغل على يعني السياسات الموجوده من اجل تنظيمها او اعاده هيكلتها. في حاجه للشغل على الستيغما اند ديسكريمينيشن وتوعيه المجتمع حول موضوع الادمان والمخدرات وخاصه حول هذه المواد الجديده. هناك حاجه كبيره وماسه نكتشف داتا جديده لحتى نعمل دراسات جديده تكون تارجتد على موضوع الكابتاجون والميثامفيتامين. وهناك امور اخرى كمان حاول يعني نشوف شو عم بيصير طرق علاجيه ناجعه، وطبعا نشوف حاجات الاشخاص المستخدمين والمعرضين. شكرا.
Thank you very much, Ellie, for that very comprehensive overview of the region. We're a little bit behind time, so could ask the next speakers to be as succinct as possible so that we can...
It's a school, right? It's a school online, so... Hello?
There are some questions.
There are some questions.
I don't know if you can see them. Any reason for missing data in Palestine?
Anna, is it possible to say on the mic the question? So actually I can read it out and we can see it here. Any reason for missing data on Palestine, e.g. West Bank, whilst Gaza would obviously be difficult? Do you want to respond to that, Ellie? Why is there missing data on Palestine in the West Bank?
There's no data from Gaza. We have scarce data from anywhere in this region. But you know the situation in Gaza and Palestine during the last few years, and this is why we are trying to have more and more. We have colleagues there in Palestine, trying to connect with them. It has been very difficult last 2 years. So we'll see how we can overcome this.
Thanks. So we'll go now to our next speaker, who is from Schoon, and I believe joining online.
Otra cosa es que te metas en el Zoom y lo hagas desde el Zoom.
If you could please take the floor, and as I mentioned, if you could please try to be succinct in your presentation. Thank you. It is Dr. Ramzi Haddad. If you're online, if you're with us.
Yeah, I'm here. Thank you. If you can hear me.
We hear you. Please go ahead. Thanks.
Yes, thank you for the invitation. So I'm gonna be brief and share. I'm a psychiatrist, so I'm gonna share a clinical experience and trafficking and all that has been already said. And as also was mentioned by previous speakers, we have very few on how many people use Captagon or methamphetamine in Lebanon, and use other drugs also. But especially for methamphetamine, there is very, very few data. So what I'm sharing is our clinical practice and opinion, feedback from colleagues, feedback from other treatment centers, and feedback also from people who use substances. They give us, if we can say, valuable information on the trends, on what they're seeing. So among people seeking treatment, Captagon has always been very, very low as a prevalence. Even before the Syria war, even after the Syria war. Before the Syria war, it's very low, but even after the Syrian war, it is low, at least in the capital and the suburbs and the region. And when we see patients and using Captagon, it's practically always not their primary substance. It's in a context of other substances and of a polysubstance use. What we know from colleagues that in the north of Lebanon, which is close to Syria, Captagon use is much more prevalent than we see in the capital, in the camps, and in mainly low socioeconomic backgrounds. And when we opened a small treatment center in the north, like 2 or 3 years ago, we start seeing more people coming, not mainly for Captagon, but using Captagon in a context of polysubstance use. I think what's more interesting is methamphetamine. As was mentioned, and as you know, methamphetamine is booming in the whole region, and it's starting to spread more and more in Lebanon. We're starting to see patients more and more taking methamphetamine and coming for methamphetamine as a primary substance, with all the negative psychiatric and medical effect that you know about methamphetamine. And patients are telling us that it's becoming more and more used and available, and their environment is using methamphetamine on a larger scale. We've done in Lebanon with EUDA and EU study on people using drugs last year, and the prevalence of methamphetamine and amphetamine was not the highest, but it was one of the main substances that people who use drugs reported. And I'm sure if we had done this study like 10 years ago, methamphetamine use would practically be insignificant or very low. But now more and more we're seeing methamphetamine, and this is a major health concern because of the difficulty of treating methamphetamine and the poor response usually of methamphetamine use disorder to treatment. So this is this is, if we can say on our feedback. I'm sorry if I'm being maybe brief, but we don't have any other data about it. If give my opinion that methamphetamine is much more a clinical concern than Captagon for the time being. Captagon may be a concern in terms of trafficking, in terms of transit region, as was mentioned in your report. But in clinical practice, methamphetamine is a major concern. Thank you.
Thank you very much. Very interesting perspectives from Lebanon. Please, to Anne.
Thank you, Matthew, and good to hear you present, Dr. Haddad. This is Anne from EUDA. Just to add, you mentioned the European Web Survey on Drugs, Lebanon findings. I wanted to mention that they are available on the SCOON website. I will, as soon as I get connected to my laptop, I will share the link with Anna, sitting here in the meeting, and she can put it into the meeting chat. The web survey, the fact sheet highlights key findings from the data collection as part of the European online web survey on drugs, which was, the data collection was last year, and now the fact sheet is available. So please do have a look at it. There is some data about prevalence of use of methamphetamine. I think Captagon was not included in the list of illicit substances in the model questionnaire developed by UDA for mainly use by European member states, EU member states. So I think that was a lesson learned, that for next round of web survey, which will take place in 27.
Amphetamine was included.
Methamphetamine was included, but
Captagon specifically, no, but probably many patients will answer amphetamine if they're taking Captagon. But it would have been, for next time to specify Captagon.
Yes, we can do that, and I think that's something that I noticed I was looking at the data on Captagon. So because the web survey questionnaire can be adapted to include country-specific substances. So that was a lesson learned from our side. So we look forward to working with SCOON in the next round of the web survey in 27. But in the meanwhile, we'll circulate the fact sheet link to you. Thank you.
Thank you. Thank you.
Thanks, Anne. I should have mentioned earlier, if anyone wants to come in at any point with questions or comments, please do so. For those in the room, if you could just put your nameplates up like this, and for those online, please feel free to either put your hand up or write questions in the chat. And if there are questions in the chat, would rely on our team behind us to signal those to us. But we'll actually now move to complement the Lebanon perspective with SIDC, represented here by Nadia in the room. So Nadia, the floor is yours.
Thank you, and good morning all, the people who are online. We participated in the study that was already mentioned. But of course, now if there is any possibility, like you have said, Anne, about like adapting more the questionnaire, we can help in that. And okay, so some reflection on what have been said and about the situation in Lebanon. Information about Captagon, it is circulated among especially young people in Lebanon, but usually they are late into requesting access to treatment or coming to the treatment or accepting that they need support. So this is a very challenging moment for parents and for or other caregivers and healthcare providers. So this is one. Second, if we are talking about methamphetamine, it is more and more circulated among youth at an early age, starting 13, maybe 14 years now. And it is very accessible among young people. It is not it is not expensive for them to access these drugs. And also, so one more thing about the situation in Lebanon, like what Dr. Haddad was mentioning, because the majority of centers and harm reduction centers are based in Beirut and Mount Lebanon, and not in other governorate. So going to the Bekaa or going to the north, it will help us understanding more the trend of substance use among, or to the south as well, among young people. And especially when reaching out to the most vulnerable persons among youth, that was said before, like MSM or other LGBT community persons, and also to the refugees, migrants now, and people living in camps like Palestinian or other people. So all these vulnerability factors that can help us to reach more to the people who are in need of such specific services. And yet, when Mr. Eli was talking about harm reduction services, so yes, we do have a needle syringe program, we do have an OAT community-based programs, and we do have outreach to most at-risk groups, but also we do need more support to reach out to different governorate and to have also a openness from the government and from the police between brackets to such a program. So this is much needed. And also we may need to revise the harm reduction kits and harm reduction programs that we already have been delivered, how we can accommodate or tailor these services to accommodate the new trend for substance use among person. Naloxone exists, but it's not always available for us as community center to be able to deliver or to train or to make it available for caregivers and families who have persons that might need it. And also because you talked in your presentation, Caroline and Eli, also you mentioned the health system and policies. We need a new strategic and strategized new policies tackling the new trend for substance use in our region. Even though that we don't have like a lot of data, we miss data, but as a healthcare provider, we know about the trends from our observation, but we need to do more research, more qualitative maybe research, to come up with new programs and tailored programs. And this is how we can overcome some of the barriers that we can do as providers. Like it is not our mandate to stop maybe the trafficking, or this is the role of the police, and we can help the police in thinking more about advancing a new approach that are more human rights approaches and not criminalizing substance use and other. But I think with all the new trend and also like when you are talking about amphetamine and methamphetamine, it is related to be more in to more awake, and young people in all their lifestyles, they need to be more energetic and to be awake, and this is why they are using these type of drugs. And we have to do a lot for different programs in school, universities, and also training healthcare providers to be able to address all these issues. So these were my point. Thank you.
Thank you very much, Nadia. We're now going to move from Lebanon to Jordan, and I would pass the floor here to Fokek, who is represented here by Abdullah Hannali. Sorry, I have difficulty reading.
صباح الخير. شكرا للدعوة وإتاحة الفرصة للمشاركة. إذا كنت سأتحدث عن الواقع الكبتاغون في الأردن، فأعتقد أننا لدينا معلومات وبيانات أكيدة ودقيقة حول هذا الموضوع. كل ما لدينا هو بالأردن إحصاءات عن ضبطيات جهاز الأمن العام وعدد القضايا المسجلة في هذا الموضوع، ولكن ليس لدينا إحصاءات دقيقة. كما أنه ليس لدينا دراسات وطنية أو على مستوى الوطن تحدد حجم مشكلة استخدام الكبتاغون في الأردن. لكن الملاحظة الانطباعية العامة وحسب الأرقام التي ترد من إدارة مكافحة المخدرات، هناك استخدام أكبر، هناك زيادة في استخدام الكبتاغون، هناك زيادة في عدد الضبطيات، يعني في بين عام 23 و 24 وحسب ما أفادت به إدارة مكافحة المخدرات كان هناك ارتفاع حوالي 30% بعدد الحبوب المهربة من الكبتاغون، حيث انتقلت من 18 مليون حبة إلى 27 مليون حبة في 24. الأردن، وكما أفاد الزملاء والأصدقاء، نحن لدينا مشكلتنا تقع في جغرافيا الأردن. الموقع الجيوسياسي للأردن الذي يقع على في قلب منطقة ملتهبة سياسيا وأمنيا وعسكريا وعلى مستوى الصراعات. الأردن أيضا ربما يكون من أكبر الدول التي تستضيف عدد كبير من اللاجئين. فكل هذا، وأيضا على الحدود الشمالية للأردن كان هناك المصدر للتصنيع للكبتاغون، وكنا قد نكون الطريق الوحيد بالأردن لمرور الكبتاغون. وبالتالي رغم كل ما يقال بأننا منطقة ممر للمخدرات، لكننا قطعا سنتأثر، وهناك زيادة في الانتشار وزيادة في حجم الانتشار. ونحن كمنظمة مجتمع مدني تعمل في المجال لدينا زيادة بعدد الحالات التي نتواصل ونتعامل معها باستخدام الكبتاغون. السياق الأردني ربما نعيش بحالة عجز، إذا جاز التعبير، عجز أمام زيادة عدد الانتشار وزيادة حجم الانتشار وزيادة المشكلة. عجز لأنه لدينا انخفاض في سن التعاطي أو في عمر التعاطي، حيث أصبحنا نرى بعمر من 10 ل 13 سنة أول استخدام للمواد المخدرة. لدينا عجز في كما الجميع في مواجهة التصنيع المخدرات والانتقال من المخدرات الطبيعية إذا جاز إلى المخدرات الصناعية، والانتقال السريع بين هذه المواد. لدينا عجز أمام الضغط على الحدود. لما اختلف الوضع في سوريا أصبحت الدرونات بتجينا من الغرب محملة بالكبتاغون من الحدود الغربية، وبالتالي هناك ضغط لتجارة المخدرات على الأردن، ربما لأننا كما أسلفت بسبب الموقع الجغرافي، وأن هناك سوق استهلاكي كبير في منطقة الخليج والمملكة العربية السعودية، ونحن ربما نكون المنفذ الأقرب والأوسع لهم. إذا بدنا نحكي عن مشاركات المجتمع المدني، كوني أمثل هذه المنظمة، لدينا مداخلات متواضعة، لأننا إذا قلنا لدينا مداخلات كبيرة من المجتمع المدني قد لا ينسجم الحديث مع حجم المشكلة التي نعاني منها، وبالتالي كل ما يبذل من المجتمع المدني هو مداخلات متواضعة أمام حجم المشكلة الكبير الذي نعاني منه. فلدينا مداخلات على مستوى الوقاية، ولدينا مداخلات على مستوى العلاج، وسبق وكان لدينا مداخلات على مستوى الحد من المخاطر. لكن هناك أيضا تحديات كبيرة أمام الاستجابة إلى مشكلة المخدرات بشكل عام والاستجابة إلى مشكلة الكبتاغون بشكل خاص. هناك تحديات في مستوى التشاركية الفاعلة بين منظمات المجتمع المدني والقطاع الحكومي، لأنه لحد الآن ما بنشوف تشاركية فاعلة بتعطي استجابات حقيقية وتتوائم أو تعالج التحديات الجديدة. وبالتالي نحن بحاجة إلى تعزيز تشاركية فاعلة مع منظمات المجتمع المدني أو مع المجتمع المدني. ما زلنا يعني نعتمد المنهجيات العقابية مع المخدرات، واعتماد المنهجيات العقابية أثبت على مدار التاريخ والمرحلة السابقة أنه لم يجدي نفعا، بالعكس هو أزاد الوصمة وأزاد التمييز وأزاد النبذ وأزاد العنف تجاه الأشخاص اللي بيستخدموا المخدرات، وبالتالي أبقى المشكلة تنمو وبحجم كبير تحت الطاولة في منطقة الخفاء. أيضا ما زلنا وربما في المنطقة ليس لدينا منهجيات في مجال الوقاية، منهجيات مبنية على أدلة علمية في كيفية التوعية والتثقيف والتعامل مع الأشخاص اللي بيستخدموا المخدرات، وما هي الرسائل الأساسية التي توجه إلى الشباب، إلى المراهقين، إلى متخذي القرار، إلى القيادات المجتمعية. وهذا ربما يكون بسبب تحدي آخر، أن مشكلة المخدرات في مثل بسيط يعني طنجرة وضايعة، بمعنى ربما أحيانا تنزاح إلى أنها مشكلة أمنية بحتة، وبالتالي هي تعود إلى إدارة مكافحة المخدرات والأجهزة الأمنية، بينما هي بانعكاساتها مشكلة اجتماعية صحية كبيرة، وبالتالي ليس هناك تناغم أو تفاعل على المستوى الحكومي بين المنظور الأمني والمنظور الصحي لبناء تشاركية حكومية أولا، ومن ثم تشاركية مع المجتمع المدني. وهذا أدى إلى تضارب المرجعية، أدى إلى يعني غياب تنسيق وقلة فعالية المداخلات التي يتم أو الاستجابات التي يتم التعامل فيها. كثير أيضا يعني في كل جريمة تحدث بالأردن تتناول السوشيال ميديا وربما أيضا جهات معينة ربط قضية المخدرات مباشرة بالجريمة، يعني الاستنتاج الأول بمجرد حدوث أي جريمة أيا كانت نوع هذه الجريمة يتم ربطها في المخدرات، وهذا أيضا يزيد المشكلة تعقيدا، لأن ليس هناك أساس علمي أو دليل واضح في هذا المجال، وأيضا يؤدي إلى مزيد من الوصم والتمييز والنبذ المجتمعي، وبالتالي يزيد من حدة المشكلة. هناك عديد من منظمات المجتمع المدني تعمل في مجال الوقاية، لكن ليس هناك إطار وطني شمولي يحدد كيفية التعامل مع مشكلة المخدرات وآليات الوقاية. مراكز العلاج، وكما أفاد سيدي لي أعرج، ربما لدى زيارتنا أو التعامل مع مراكز العلاج والتأهيل في الأردن رغم محدوديتها، يعني بالأرقام كل ما لدينا ربما لا يزيد عن يعني 200 سرير في مراكز علاج الإدمان الحكومية، وهذا هذا رقم متواضع أمام مشكلة المخدرات الكبرى بهذا المجال. وبالتالي إشراك المجتمع المدني أو توفر منهجيات علاجية حتى رغم خلينا أعيد ترتيب الفكرة. ترتيب الفكرة أنه مراكز العلاج محدودة جدا، منهجيات العلاج داخل مراكز العلاج قد تكون محدودة أو قد تكون لا تجدي نفعا، لأن منهجيات العلاج قائمة على الفطام وليس هناك منهجيات متنوعة ومختلفة. ولا يشرك المجتمع المدني أيضا في مداخلات الرعاية اللاحقة وتهيئة البيئة للأشخاص اللي بيتلقوا العلاج وإعادة التأهيل لضمان نجاعة أو زيادة نسبة نجاح التوقف عن استخدام المخدرات. الأمر ربما الأخير سأتحدث عنه، الرفض المطلق لمنهجيات الحد من المخاطر. يعني وهنا في تخوف لدى القطاع العام بالأردن من منهجيات الحد من المخاطر، رغم الاتفاق على أنها منهجيات قائمة على مفاهيم الصحة العامة وقائمة على منهجيات حقوقية، ورغم أنها لديها أدلة علمية تثبت نجاعتها ونجاحها، إلا أن هناك منظور سلبي تجاه استراتيجيات الحد من المخاطر، الأمر الذي يعني يشكل عائقا كبيرا ويشكل محدودية الخيارات أمام الأشخاص اللي بيكونوا سبقوا استخدموا المخدرات أو أنهم يعانون من اضطرابات استخدام المخدرات أو اضطراب الإدمان على مواد مخدرة. هذا ما وددت أن أقوله، وأستمع للأسئلة وشكرا.
Thank you very much. And all of these contributions are
شكرا جزيلا. كل هذه المساهمات مهمة جدا ومجددا تبين أهمية صوت قوي من المجتمع المدني وكذلك مساهمته بالإضافة إلى وكالات إنفاذ القانون. وإذا هذا موضوع مهم جدا. أعتقد أن هناك سؤال أعتقد أردت أن تساهم به. سيدي، لقد ورفعت اليد في خانة الدردشة وترغب في أن تطرح سؤالا، أليس كذلك؟ ربما سأتدخل بعد الأسئلة. مايكروفون بليز. مايكروفون بليز. عفوا، أنا لا أستمع إلى المتحدث. كان هناك سؤال يتعلق باستخدام من باكستان، وأعتقد هذه العدة أو علبة العدة. نعم، لقد اطلعت على البريد الإلكتروني، ولكن يمكن أن نناقش هذا لاحقا. بالنسبة إلى العدة التي بها المحثات أو المحفزات، فربما سوف يكون لدي اجتماع للمدير الإقليمي لمنظمة الصحة لكي نناقش نوعية الخدمات وآثر هذه العدة في تخفيض الإدمان.
Model of harm reduction services for non-injecting drug users. So maybe it will be our next priority very soon. We can communicate next week, you and me. Thank you.
Thank you, colleague from Jordan, for your very comprehensive overview. A couple of just information points. The EU 4MD project has set aside funding for collection of data among school pupils in the age group 16. This is as part of the so-called MEDSPAT, Mediterranean School Survey on Drugs, which is the Mediterranean adaptation of European School Survey on Alcohol and Illicit Drugs, ESPAT. So with the Pompidou Group and Council of Europe, we have trained the officials from Ministry of Education and Anti-Narcotics Department. They were trained by the ESPAT team of experts from the National Research Council of Italy. The training took place in Amman in September last year. I am following on this development. The A&D officials attend all the relevant meetings, including the Council of Europe Pompidou Group organized MEDSPAT committee meeting in Paris a few weeks ago. However, we are not really seeing progress from the Ministry of Education side. So I think it would be helpful for the civil society to ask about, because you mentioned about the lack of national level data about drug use. So we have been trying to move towards, having the Ministry of Education to implement the survey, but they need to work on it. I think it's very difficult to know what are the challenges or the obstacles for, actually making the data collection happen. So maybe that's something just for you to know, that we have funding set aside. Anytime they're ready, we are ready to support. The second point is about science-based prevention. Last July, the team of our Lebanese team of EUPC, European Prevention Curricula trainers from Lebanon, Rasha Bihana and Hala Naim, many of you may know them, they went to Amman and trained some 20 officials from the A&D on science-based prevention, effective approaches to primary prevention of drug use. This was the start, it's not the end, because we all know that a one-off training workshop is not the solution. So I think we need to look at how we can incorporate some of those training materials that exist, and I think we may need to translate them into Arabic, how we can incorporate them into maybe the police academy. Yeah. Sorry. Yeah, I am. Sorry. Yes. So just to summarize, data collection at national level is possible if the Ministry of Education takes the lead. And on the prevention, we organized a workshop it was the basic modules, and all stakeholders from Jordan and all countries globally, anyone, anywhere in the world can register interest to participate in the EUPC. It is the European Prevention Curriculum training courses. There is a registration link on EUDA's website. We can circulate the link in the meeting chat, and anyone can register interest. People in EU need to pay if they want to travel to Lisbon or Germany, where the trainings normally take place, or the trainings are increasingly also available online. So there is an ongoing training program on prevention. Anyone can register. There is a basic modules course, which is usually 3 days on average. And then there is an advanced self-paced learning course on EUDA's e-learning platform called Plato. And this takes a few months. And then those who successfully pass the basic modules and advanced modules can participate in a TOT, which is always face-to-face. And then those who pass the TOT get a certificate, and they are accredited to train others. So this is just one of the resources available from EUDA for anyone to use. Thank you. Sorry if I took the time, but I think these are useful.
Thank you, Anne. No, indeed, I think the idea today is to have a conversation. Absolutely, so very useful. We have 2 questions or comments from the room, so I'll go first to IDPC. Adria, the floor is yours.
Yes, now you can hear me. Hello. Good morning, everyone. I'm Adria from the International Drug Policy Consortium. We're a network of civil society from around the world. MENA is a we're proud to have MENA as one of our members. And also just to say what a great meeting so far and so much information. I don't know if there will be an opportunity to share presentations after like the slides, but it would be really, really useful if we could have this because it's been so good. Just on my end, a reflection, looking at the recommendations part that you mentioned, Matthew, that you wanted to discuss. It's clear that there's lots of resistance to harm reduction, lots of lack of knowledge around harm reduction. So super important if any outputs of this space dedicate space to harm reduction, not only a reference at some point, but like a genuinely like substantive space to communicate about it, to explore it, to explain what it is, to provide references that would comprise, I don't know, like reports, but also follow-up meetings. I think that's very important. And then try to break away from harm reduction as only a technical response to injecting drug use, right? That's the issue we have. It's very prevalent, of course, to look at harm reduction this way, very prevalent in international spaces, but it's a very, very old, like outdated approach to harm reduction. It's not the reality nowadays. There's technical responses to harm reduction for methamphetamine from stimulant methamphetamine use that are like it's not new. It's been happening for decades around the world. So they exist. There are resources. So I would strongly recommend that these are included, and also to have the reflection that harm reduction is not only a technical response. It's an approach to drug use. It's a full spectrum approach to drug use. So if we are facing lots of Captagon use that's due to extremely hard working conditions, extremely hard living conditions, a harm reduction approach is one that looks at those drivers of that problem with drug use and tries to address them. So I think we all know this in this room. It's nothing new. I'm not saying anything groundbreaking, but just to try to say it once, like over and over, and make it very clear in the outputs of this meeting and this space, and work program would be super useful. Thank you.
Thank you very much, Adria. I'm afraid I can't see your nameplate from here. So if you could maybe introduce yourself.
Yeah, good morning, everyone. My name is Quds. I'm from a local association in Tunisia, named the Tunisian Association for Fight Against AIDS and STIs. So my question is going to Caroline. If I'm not mistaken, you already showed that when it comes to drug Captagon, that there is a lot of forms. It means that there is a lot of shape. There is a tablet, pill, something like that. If I'm not mistaken, if I understand very well, that it's this related to the pharmaceutical campaigns. So do you ever think, I'm thinking out loud with you, do you think it's a kind of evergreening related to
Sorry, can you go slowly?
Yeah, please. Okay. So do you think it's a strategy related to the pharmaceutical campaigns every time they change the form to extend the license? So we call this, when it's related to intellectual property, we call this, it's evergreening, just to change the shape of the drugs or something like that. Do you think in this area or not?
That's a great question. So the reason why Captagon is called Captagon, it was a German pharmaceutical company back in the 1960s, gave the brand name Captagon. When Captagon was scheduled, World Health Organization, and became an illicit substance in the mid-1980s, that's when we continued to see the illicit production of Captagon with the original phenethylene formula, but still using the brand logo of Captagon. And so we define Captagon as an amphetamine type stimulant that has essentially the brand and the logo of two interfacing C's. Sometimes it's called Abu Hilalain, father of the two crescent moons, because they look like two crescent moons. Where Captagon becomes tricky, and I think that you mentioned this, and what producers are trying to do, they're trying to replicate the original formula through a variety of different ways with pretty much whatever they can get their hands on. Sometimes there is no amphetamine whatsoever included in Captagon tablets. Sometimes there's a lot. Captagon also has other additives like caffeine, quinine, a number of other chemical additives. Also, we've started to see Captagon have the imprinted logo differ from the two moons. Two popular logos that I wouldn't say popular, but two secondary and tertiary logos that we've seen. The Lexus logo from the popular car brand Lexus that first appeared on plastic bags, but now we're starting to see it imprinted onto the face of the pill. And then head of a horse, or sometimes the whole horse, representing the Lamborghini car logo. I don't know why it's always associated with a car logo, but we have Lamborghini and Lexus primarily. We've also seen the use of Roman numerals sometimes on the back of pills. In Iraq, it's often referred to sometimes as 01. So there could be an association with Roman numerals and the nickname, the street name of Captagon is 01. But all to say, we've seen a huge diversification, I would say even in the last 3 years, when it comes to the branding that could correspond to a different chemical composition of Captagon. The laboratory analyses that we received from German police and the Jordanian Anti-Narcotics Directorate is a great start to understanding how these producers are trying to diversify the chemicals. But it's nowhere near, consistent analysis that can help inform us what consistently is comprising these different brands, so to speak. I do think it is a strategy amongst producers. It's not just about the availability of these chemicals, but it's also about trying to put forth different brands for different types of use. We've heard today Captagon can be used for weight loss. It can be used for recreational purposes. It can be used for productivity, for studying or for staying up late at night. So as a result, we've seen these different types of street names and corresponding colors and chemical formulas emerge. And we just simply don't have enough data about it. And I think the shape, the color, and now, of course, the imprint, it's starting to correspond to those different brands.
Thank you, Caroline. We have a question online, which I think is probably following on directly from Adria's point about harm reduction services. So I'll read out the question, which is, are there any available resources on methamphetamine and Captagon harm reduction usage that we can share with our communities in Arabic? What they are, harm reduction, where to get help, and what services are available, and what side effects or dealing with overdose. This information would be very valuable to communities who cannot reach out to public services and have to deal with them on their own, especially among key populations. So for that question, I'd maybe go very quickly, just in 1 or 2 minutes. We're quite behind time, to maybe IDPC, then EU 4MD, EUDA, and then finally to MENA, and then after that we can go for a break. So Adria, would you have a response to that question?
The answer is I don't know. In Arabic, I can definitely point to a list of resources in English that maybe we can put on the chat in the afternoon. And I can also ask around, but maybe in Arabic, colleagues from MENA are more familiar than I.
Thanks. Anne, any resources on this through the EU 4MD project?
Resources in terms of the question that is in the chat. If I can see it, methamphetamine, Captagon harm reduction. To be honest, EUDA has not developed specific harm reduction guidance in context of methamphetamine or Captagon. Our latest public health guidance on harm reduction responses is still very much about people who inject drugs. I'm aware that UNODC has some guidance on treatment of stimulant disorders, and there is an ongoing collaboration with UNODC headquarters and the EUDA to look into the treatment of stimulant dependence So I would say that the guidance is forthcoming by UNODC and EUDA. It's in development. At the moment, no, unless Julie from UNODC has updates. No, this is it. Yes, not ready yet. But there was a recent meeting about treatment of stimulant dependence.
Thanks. And Ellie, from your side, anything on resources on harm reduction or recommendations on that topic?
Frankly, it's still at the beginning. There is a component that wasn't mentioned. It's about the increase also of the chemsex use among especially men of sex with men, and some studies were conducted, and of course we will build on the results to create some resources and material for harm reduction. As I mentioned, also we have for the services we will discuss with the WHO regional director next week the issue of supporting the civil society in the spread of the services, because we faced some resistance when we talked about the, let's say, pipes or other issues. But I wanted to say about the space for the civil society. I can say that I will use two examples. One in Lebanon, when we started the needle and syringe distribution, it was in 2000, and it was in a somehow clandestine way. When the police knew about it, we were threatened by the prison. Until a few years ago, the Ministry of Health published a statement saying that because of this service, we don't have any new HIV infection among people who inject drugs in Lebanon since more than 10 years. And this is how we pushed and we advocated, and the civil society were the main base of the development of the National Strategic Plan on Substance Use. The second example is recently, MENA is working in Egypt with the Ministry of Health and other colleagues. We used the opportunity of the presidential initiative to eradicate HIV, and they had a target 100 million health. They reached it, and they are pioneer in the world. So this is how we could manage to go through harm reduction services with frontline aids and with the support of Unit 8. We are conducting 3 studies on loaded space syringes, on long-acting buprenorphine, and to create a community model of care. But also on Tuesday, sorry, we had a call with Bristol University, because they are contracted by Unit 8 to conduct a study on cost effectiveness. I think this kind of studies can help us to show that harm reduction services are beneficial for the national economic, but also for the community. So we are on the track. It's slow. The security weight, people, the law enforcement and others is very strong, but we are trying to do our best.
Thank you very much. Now we're actually very behind time, being told we need to caffeinate these people. So let's break quickly for a coffee break. If you can hold your questions, sir, until after the break. So we have half an hour in the program. If we could reduce that to 20 minutes and be back here in 20 minutes, please.
Just one thing, that I don't have any question, but actually my name is in the agenda, so this is why I prepare some points according to HIV and Law Initiative, and that's it. So this is why I said that I will.
Apologies. We'll come to you directly after the break.
And I'm going to say 15 minutes because I know it's not going to be 15 minutes. So I'm going to say 15 minutes for the coffee break.
Test check.
Okay, so I think we can restart. A reminder to everyone intervening. I've received a reminder from the interpreters to please speak slowly, and I think I am one of the worst offenders in that respect. But we'll now go directly to Mr. Mohammed Al Nasser, who we missed in the initial presentation, which is my fault entirely. So I apologize again for that. But over to you.
Thank you very much. No, actually, not at all. I will not take more time because my colleagues they covered most of the points. I'm gonna speak in Arabic, so just for the because of the translation. I mean, أنا بدي أسلط الضوء على كم من نقطة. أول شكرا جزيلا لإعطائي هاي الفرصة للنقاش. بس أنا حابب أعمل زي أفرق نقاط لازم تتوضح بما يتعلق في الكبتاغون. الكبتاغون في الأردن هي مشكلة حقيقية وعم تزداد شيئا فشيء. كان بالأول بغض النظر في منحنى سياسي. المنحنى السياسي له دخل في تلام الأردن من قبل دول الخليج، بعض دول الخليج المجاورة، إنها معبر وممكن أن يصل مادة الكبتاغون لإلها بسبب إنه الأردن ما عملت حماية لهاي الحدود. وبنفس الوقت كان الفكرة الأولى اللي موجودة إنه كان النظام السابق في سوريا هو اللي كان فقط يمتلك موضوع الكبتاغون بسبب الحصار، ولكن بعد ما ذهب النظام السابق احنا لازلنا قاعدين بنشوف في كبتاغون في البلد وقاعد تزيد الاعداد. يعني بالنهايه هي وسيله لصنع المال يعني بشكل او باخر. فاول شغله المنحنى الامني لازم اوضح انه في حروب على الحدود بسبب هاي الماده. الحروب هاي ممكن قاعده الحكومات قاعده تدعي ان هناك عصابات يعني شبكات جريمه منظمه هي التي تقوم بإصدار وتهريب المادة المخدرة وهي الكبتاغون من دولة إلى أخرى. هذا يسبب ضغوط على الأجهزة الأمنية وتكلفة باهظة لأنه في حماية دائمة بتكون موجودة. من منظور قانوني أنا يعني حاب بس أنوه إنه أغلب الدول العربية هي عندها تتفاوت العقوبات، تفرق ما بين مستخدم المخدرات أو بشكل عام وهو مستخدم الكبتاغون هو يعني ينطبق عليه ما ينطبق على مواد المخدرة الأخرى. الشق الآخر هناك تجارة، والتجارة أعني بها بالتجارة الداخلية، برضو تختلف العقوبات كليفل عقوبة، ولكن يفرق القانون ما بين التجارة واستخدام المواد المخدرة. وآخر شيء هي التهريب. التهريب هي تأخذ أعلى نسبة عقوبة، واليوم إحنا عندنا مشكلة إنه إلى هاي اللحظة مش قادرين يستوعبوا الفكرة إنه مستخدم الكبتاغون هو شخص بحاجة إلى رعاية، ولازلنا إلى هاي اللحظة قاعدين نتهم من يستخدم الكبتاغون إنه هو قاعد يساهم في تنظيم الجريمة مع العصابات التي تهرب كما يتم الادعاء. شو السبب بذلك؟ السبب بذلك إنه المادة الكبتاغون مادة سريعة التحول من حبوب إلى نقود، فبالتالي بدون رقابة، دون رقابة. ما يحصل بهذه القصة إنه يتم في بعض الحالات استخدام الأموال التي تحولت من شكل كبتاغون إلى شكل أموال في تمويل الإرهاب حسب ما يدعي العديد من الدول. وتمويل الإرهاب هي مشكلتها إنه ما فيش تراكينج، ما فيش مراقبة على وين النقود رايحة. فهذا الحكي طبعا في له بالماضي كثير أمثلة، مثلا لما كنا نحكي عن بابلو اسكوبار لما كان يهرب الكوكايين من دولة إلى دولة، كان الدولارات تخرج من بلد معينة إلى بلد أخرى، فبالتالي صارت الحرب أين هي النقود، مش الحرب من هو الذي يستخدم هاي المادة. فهو وسيلة الوقف اللي قاعدة بيعملوها قاعدين بيركزوا على مستخدم المخدرات، وهذا أعتقد إنها في مشكلة حقيقية، لابد أن يكون هناك تفريق واضح ما بين مستخدم هذه المادة وما بين خلينا نحكي الجماعات التي تخطط لتهريب المادة الكبتاغون من دولة إلى أخرى. فمن ناحية قانونية احنا صح عندنا تفريق بسقف العقوبة، ولكن إلى هاي اللحظة هي جريمة. وهذا الحكي انه دائما بنحاول نحكي انه لا يا جماعة، انه اللي بياخذ هاي المادة هو بحاجة إلى رعاية، مش بحاجة إلى عقاب، لأنه بداخل السجن حتى ممكن يكون موجود مادة الكبتاغون مش بس بخارج السجن. فبس حبيت أسلط الضوء على الناحية القانونية بهذا الشكل، لأنه الموضوع السياسي والموضوع القانوني اللي قاعدين بنواجهه في المنطقة وخصوصا في الأردن لأنها معبر مهم، لأنه في سوق كتير كبير موجود في دول الجوار، وفي سوق كتير مصنع برضه بدول الجوار. فبالتالي حبيت أنوه على بعض النقاط القانونية فقط، مش أكثر من هيك. يعطيكم شكرا.
Thank you very much. And I think it's a very important point about needing to avoid stigmatizing the users, and hopefully we can have some recommendations in the report on that topic. We'll move now to a presentation on Iraq by the Humanitarian Rehabilitation Association for Education and Health, who I believe should be online. I don't have a name, but if there is a speaker from that organization online, please go ahead.
No, it's not online.
I do apologize.
Hi, I speak Arabic. اسمي زينة، أنا مؤسسة جمعية للتأهيل الإنساني للتعليم والصحة المعروفة بألفا العراق. عليه. أوكي. اولا شكرا انه دعيتونا اول منظمه من المجتمع المحلي عراقي تكون موجوده بهيك حدث كثير مهم، خاصه العراق يكون دائما غايب عن هيك ندوات وهيك شغلات مهمه. نحن جمعيه تاسست كفريق من الطلاب والاكاديميين والاطباء ب 2017 بالنزاع النزوح بحرب داعش بالموصل والانبار، وسجلنا رسميا بال 2020 كمنظمه محليه. غرضها هو تمكين المجتمع المحلي العراقي حصرا من خلال التعليم بالصحة بالتعليم خاصة والصحة، ودخلنا وذلك لقوتنا بالمجتمع المحلي والتواصل السريع معهم وإيصال فكرة بعد أوكي وإيصال أنه أدنى القدرة أنه نكون بالمجتمع المحلي لفهمنا المجتمع المحلي العراقي وكيفية إيصال الفكرة عن طريق البرامج التي تبثها الأمم المتحدة أو المنظمات الدولية، وذلك لمعاناة المنظمات الدولية بإيصال أو إكمال المشروع بالعراق بسبب تدخلات الدولة أو بعض أفراد الدولة، خلينا نقول المرتشين، أو عدم إمكانية إكمال البرنامج في المنطقة. فدورنا بهذه البرامج نحن بالعراق خاصة بأهمية استدامة المشروع ووصل فكرة المشروع والهدف منه أنه بناء قاعدة كتير قوية بالمجتمع المحلي. وكانت أول تدخلاتنا وحاولنا نتدخل فيها مع مسيو إلي بموضوع ال HIV الخاص بالصحة، وذلك لانتشاره وعدم وجود بيانات وداتا صريحة تخبر عن المستوى ال HIV والأمراض الموجودة فيه وتوسعها. فكان هذا دورنا بالمشروع الأول إلى أن فتنا بمسألة الإدمان، وهي كانت كتير مهمة، وذلك لانتشاره وعدم وجود أي توعية بالمجتمع المحلي أو عن طريق كيف انتشاره أو الأدوات التي يتم بها انتشاره واستهداف الشباب والنساء خاصة، وغياب مراكز التأهيل عن الطرائق أو طرق العلاج الحديثة أو طريقة العلاج النفسي خاصة للنساء، لوجود وصمة عار للشخص المدمن في العراق وعدم تبليغ أنه هو مدمن، واتخاذ الحكومة العراقية قرار بتخيير الشخص المدمن بالسجن أو بالدخول إلى مراكز التأهيل للعلاج، فيختار مراكز التأهيل للعلاج للهروب من السجن. لكن لا يوجد متابعة بعد العلاج، هل هو استمر أو رجع للإدمان مرة ثانية أو شو صار معه بعد الخروج. والبرنامج المعتمد للإدمان بالمراكز العراقية هو البرنامج المتبع من WHO فقط لمدة شهر واحد، هو تنظيف الجسم المريض المدمن من السموم، لكن لا يوجد مراجعة نفسية أو تدخلات نفسية واستشارات. هذا كله بسبب فترة للرجال فقط، أما غياب الدور للنساء لاعتباره أن المرأة المدمنة هي وصمة عار للمرأة المدمنة بالمجتمع العراقي، اللي إذا عندكم فكرة عنه مجتمع كتير متحفظ. كان مرض الكورونا، المصاب بمرض الكورونا من النساء لا تتزوج، كيف الحال إذا كانت مدمنة؟ فهذا الأثر أنه لا يوجد أي داتا واضحة وصريحة للعلاج المرأة، ولا توجد أي مراكز تأهيلية للمرأة لا للعلاج النفسي ولا أي وين أصبحت هي بعد العلاج أو كيف كانت. والغرض منه اللي هي الإتجار بالبشر أيضا موجود، وسببه أيضا الإدمان اللي هي تعتبر وسيلة ضغط على النساء، والعنف الجنسي والاضطهاد ضد المرأة خاصة. هذا غياب المواد الأكثر تصنيعا، باعتبار العراق هو بلد مستهلك ومنطقة عبور بين الدول العربية، وهذا الإهمال كتير خطير لأنه يعتبر منطقة الوصل للخليج وبلاد الشام. أصبحت محافظة متنب 2023 وهي منطقة وصل بين الجنوب والوسط، هي معبر للخليج، منطقة منتجة للميثامتين. فهذا الإنتاج هذا الإنتاج بمنطقة المثنى لا يوجد أي إحصائيات أنه هل تم إغلاق المعمل المنتج أو خاصة بعد تغيير النظام في سوريا. المنطقة الغربية والحدود مع سوريا مضبوطة من قبل الدولة، لكن المنطقة الجنوبية والوسطى واللي هي تكون محاذية وبلد الجار هي إيران لا يوجد كثير تفاصيل أو داتا واضحة على التهريب والتصنيع لدول الخليج. غياب الوعي، استهداف المنطقة الجنوبية خاصة هو غياب الوعي وعدم وجود توعية بالمواد المصنعة وأضرارها بين الشباب والنساء، لقلة التعليم وزيادة التخلف في هذه المنطقة، خلينا نقول أكثر، والفقر بتوجه الشباب خاصة لهذه المواد، لأنه هي تعتبر نتيجة هروب لهم. لكن الآثار الجانبية لها عم نشوفها بالمجتمع حاليا هي العنف الأسري الزاد حاليا بنسبة 70% إلى 80%، حالات الانتحار بين الشباب اللي أعمارهم بين 23 إلى 25، كل هذه الأضرار بسبب غياب التوعية. نحن دورنا كمجتمع مدني حاليا نعتبر حالنا أنه نحن عم نوازن بين جهتين، هي الدولة والمجتمع المحلي. لدينا صوت بالمجتمع المحلي وأيضا تعاون مع الدولة، نستطيع عن طريقها إدخال البوليسي والإجراءات المهمة والأسس المهمة للتوعية بالجامعات. لنا دور كبير بالجامعات لأن الفريق يقسم إلى شقين، تعليمي وطبي، لكن غياب البوليسي الحديثة، الورش، التدريبات، بناء القدرات، نحتاجه بالمجتمع المحلي أكثر، خاصة الإدمان والأمراض المعدية. نحن لدينا القدرة أن ندخله للمجتمع المحلي، وخلينا نقول نعمل بروسيجر جديد أو بلان جديدة وإنجاحه على الأقل، وبناء داتا تستطيع الدول أو المنظمات الدولية تعتبرنا مرجعية للداتا، لأن حتكون موثوقة وصريحة في حال أنه بدنا نعمل شبكة نستطيع التواصل مع المنظمات الثانية والاستفادة من الخبرة تبعها. نحن يعني خلينا نقول نتمنى كتوصيات من المجتمع المدني أو منظمات المجتمع المدني نكون في مراكز تأهيلية متطورة للكوادر اللي عم تشتغل بالتأهيل بهذه المراكز، الأطباء، إنه في بوليسي إنه فينا ننشرها بالجامعات والمستشفيات. لدينا القدرة على ذلك. هاي نتمنى أن نقلل ونكون نحن الجهة اللي تبين إنه في خلينا نقول خففنا من هذا الضرر أو قللنا منه أو وعينا، لأن التطور بالمواد المنتجة اللي عم تدخل وخاصة الكبتاغون عم يدخل على شكل أشرطة أدوية، يعني عم تستخدم بالصيدليات أو عم تستخدم بالجيم أو عم تستخدم كالنساء كمواد منحفة. فهذه التوعية كتير ضرورية، وخاصة بالمجتمع المحلي، إنه وجود هيك إشي عن طريق المنظمات المجتمع الدولي. وهون دورنا نحن نستطيع بالتعاون مع منظمات دولية أو مع منظمات مجتمع إنه صوت، صراحة إنه صوت على الأرض نقدر نوعي، وخاصة إذا بلشنا من الجامعات والمدارس. التيم المانجر فور عراق هي دكتورة كيميائية، كيمياء تخصصها كيمياء سريرية وتشتغل بالصحة، لديها وضع يعني رؤية كاملة عن الوضع العام، وتعرف أنه كيف بلشت الأدوية والكبتاغون كيف دخل للعراق عن طريق دواء للأطفال اللي عندهم فرط حركة يستطيع استخدامه، وأصبح هو مبرر للانتشار داخل العراق، ومن هنا بدأت التجارة فيه والدخول والاستغلال له. شكرا لكم وشكرا على الاستضافة.
Thank you very much for that very interesting input. And of course, Iraq, talking about the response, is also one of the countries that uses the death penalty for drug trafficking. And as a point that we made yesterday, this also complicates the exchange of law enforcement data with Iraqi police services in drug trafficking cases. Just a little aside. On the agenda next, we have the Syrian Red Crescent, and I'm told that they're not online because of the issues in the country at the moment. However, it would not be the first time I've been wrong today if that's not the case. But if they are, please jump in now. But otherwise, I will jump to Tunisia, and we have a representative here of Atios, Dr. Hedia Karawi.
Bonjour, je suis pas la présidente Hedia Karoui, c'est notre... D'accord. Pas de français. سامحوني باش نتكلم العربية. أنا لست رئيسة الجمعية، هي هدية الدكتورة هدية الشواشي، ولكن أنا عضوة ناشطة حاليا، وكنت منذ 12 سنة كاتبة عامة للجمعية التونسية للإرشاد والتوجيه حول السيدا والإدمان، اللي هي تعتبر جمعية عريقة في هذا المجال، أحدثت من 92 للتعهد ومساعدة المتعايشين مع فيروس نقص المناعة. وعند انتشار استعمال المواد المحقونة في بداية الثلاثينات اهتمت بمجال الإدمان وخاصة بفئة المتعاطين المخدرات المحقونة. ووقع تكوين الفريق المتدخلين في هذا المجال في برامج التكوين المنظمة عن طريق منارة، اللي نجد شكرنا كل مناسبة لها. ووقع إحداث أول مركز ببرامج تقليص المخاطر في 2011. ومنذ ذلك الوقت عملنا على تذليل الصعوبات لولوج هذه الفئة للخدمات الصحية، وكونا متدخلين مربين نظراء للاتصال بهم في أحيائهم لتفادي مشاكل، خاصة معناها المشاكل الأمنية، خاطر في تونس باقي كل المخدرات ممنوعة، وصار في تخفيف للمقاربة الجذرية. فما اعتراف بالعلاج حاليا، ويمكن لأي متطوع بمطلب رسمي للعلاج أن تسقط كل التتبعات العدلية التي تثار بعد تاريخ إيداع المطلب. ولكن مريض الإدمان في تونس ليس له الحق بالتمتع بالتغطية الاجتماعية، فعليه التعهد معناها وتحمل مصاريف العلاج. ولذلك تبقى الجمعيات هي المتدخل الأكثر في مجال المستعملين المخدرات المحقونة والأفيونات، اللي هم يعرفوا صعوبات مادية وتعتبر فئة مهمشة. لذلك يلتجئوا للجمعيات كما أساسا أتيوست هي اللي مسؤولة الأولى على هذه الفئة، لكن هناك جمعيات أخرى كما لاتيال اللي هي تهتم زادة بالفئة هذه. لكن من حيث الدراسات، دراسة السلوكات المحفوفة بالمخاطر لدى هذه الجمعية تبقى عند أتيوست، وهي منذ 2009 تقوم إلى 2021، دونك كل 4 سنوات بدراسة للتعرف أكثر على هذه الفئة ومدى تغيير السلوكات إلى غير ذلك. ويبقى دونك استعمال سوبيتكس اللي هو العلاج النهض للأفيونات مستعمل بالأساس بطريقة غير قانونية. وتسعى تونس وبدأت منذ 2 سنين ممكن للنساء أولا، وإن شاء الله في القريب العاجل بالنسبة للرجال في علاج النهض للأفيونات عن طريق الميثادون. دونك كما قال الدكتورة بدران، هام برشا ان احنا نغيروا ولا نطوروا ونعددوا البرامج نتاع تقليص المخاطر للفئات الاخرى. خاطر الفئة وقت نعطيوها الخدمات هي وقتها نجم تتجهلنا ولا نجم نمسوها عن طريق الخدمات هذه. لكن كما نعملوش برامج تقليص مخاطر الفئات اللي هي تستعمل مواد أخرى، فهي لا تقدر على الولوج للخدمات الصحية اللي تعتبر مكلفة مثلا في المجال العام، المؤسسات الحكومية مكلفة، فبالتالي ما نستطيعش التعرف على هذه الفئة. شخصيا أنا نعمل في الجمعياتي وفي الحكومي، إلى حد الآن ما سمعتش بمستعمل كابتاغون في تونس. جست وقع انه استدعاتني جمعيه متاع شباب صغير باش نحدثهم على الماده هذه. انا مشيت نبحث باش نتعرف عليها اكثر باش نجم نجاوب على اسئله متاعهم، لكن كي سالتهم شنو علاش تهتموا بماده كيما هذه مش موجوده في تونس على حد علمي. خاطر انا كسوا عن طريق اتيوست والا القسم اللي نعمل فيه نتعاونوا مع الايو دي للتحضير مع المعهد الوطني للصحة للإحصائيات متاعنا نشارك فيه. ما ريتش معناها جهة رسمية تقول عنا المادة هذه. الميثامفيتامين مرة واحد قال لي نستعمل فيها وتحافظ على مصادر كان إنسان فنان وتحافظ على مصدر منين يلقى هذا، لكن يقول لي ماهوش متوفرة ديما زادة، معناها يحصل عليها بشقاء ومن مدة لمدة. لكن زاد كيف الشباب هذايا كتلبني الاجابات نتاعهم كي قلت لهم علاش تهتموا بماده غير موجوده، رماو على البلدان الاخرى، معناها هو موجود ياسر توا في سوريا وفي العراق وجو سي با كوا، وحنا كشباب نسافروا ونشوفوا لازمنا نعرفوا باش نحسوا. دونك بالنسبه لي انا نقطه استفهام الاهتمام هذايا. ودونك الجمعيه نتاعنا زاده كيف هي بما انها كما قلت تخدم في مجال استعمال الحقن اللي ولات عندها حاليا 4 مراكز معناها تتدخل نجم نقولوا في تونس الكبرى الكل، وين تتواجد معظم معناها مستعملي المخدرات المحقونة في تونس، وكذلك في الشمال متاع تونس في بنزرت عندنا زاده مركز اللي يمكن الخدمات كله مجانيه وفيه البرامج الكل متاع تقليص المخاطر باستثناء الميثادون اللي هي مازالت في المؤسسات الحكوميه في تونس. دونك ساهمنا مع المعهد الوطني دونك محمود يعقوب في الدراسه اللي عملوها على المياه المستعمله ولا على الحقن المستعمله، ومديناهم دونك من الجهات هذه الكل ممثله في الفئه، والدراسه باش يقدمها لكم دكتور مصلح. شكرا ويعطيكم الصحه على الدعوه.
Thank you very much for that perspective on Tunisia. We also have Voluntas in the room. I don't know if you want to add anything from the perspective of completing the picture on Tunisia, but no need if not. But
علي بن جدي من مركز فولونتاس للدراسات والأبحاث. في الحقيقة شكرا للدكتورة على المداخلة القائمة جدا في علاقة بظاهرة المخدرات في تونس عموما ومادة الكابتاغون والميثامفيتامين تحديدا. وأنا يعني أشاطرك الرأي في علاقة بتوفر هذه المادة في تونس، يعني نادر جدا وجودها، ولم نسمع بحالات تعاطي أو إدمان لهذه المادة. يمكن هناك إدمان على مواد أخرى القنب الهندي مثلا، أو الكوكايين، الهيروين أو مواد أخرى، ولكن الكابتاغون والميثامفيتامين حقيقة لا وجود لحالات كثيرة لتعاطي هذه المادة. ولكن جدير بالذكر بأنه كان هناك عدة محاولات إحباط تهريب يعني كبيرة لهذه، كميات كبيرة لهذه المادة في تونس، تحديدا من مثلا من ليبيا، من ميناء لبنان، وكان كميات بالملايين الحبوب من مادة الكابتاغون. هذه معطيات موجودة ومتوفرة على المواقع والرسمية وأيضا الصحفية والجمعياتية التي تعنى بمتابعة هذه الأخبار في الشأن في الحقل يعني نتاع الإدمان والأنشطة هذه. ولكن هناك برامج وهناك مقاربات وقائية لمكافحة هذه الظاهرة، وهذا مجال ومناسبة جيدة حتى نفهم نحن في تونس ما الذي ينبغي علينا فعله لمكافحة هذه الظاهرة، وربما الاستعداد أكثر وتحضير أنفسنا أكثر لمجابهة هذا الخطر. هذا هو. شكرا.
Thank you very much. Now we have 2 questions from within the room. I'll go first to Aisid.
شكرا جزيلا EU Act وللجميع. أنا فضولي شوية وبدي أكتر تفاصيل من أمينة العامة من أتيوست لو سمحتي. في بلدان أخرى وفي مجالات أخرى لما وجدنا إطار قانوني اتحد ضد المستهلكين والمستهلكات، نرى أحيانا صعوبات معينة للعمليين في المراكز. وأنا فضولي إذا ممكن تحكي شوي عن صعوبات المعينة للعمليين المراكز مركزتك أو مركزتكم. ممكن صعوبات من جرى صحة نفسية للعمليين أو حتى خطر بالنسبة للقانون أو حتى مع العلاقات الاجتماعية لديهم أو la perception de la société إذا في.
في البداية صحيح حتى الاسم الأول مركز حكومي وقع إنشاؤه في 98 هو اسمه مركز الإنصات والوقاية والعلاج دون ذكر، وكان دون ذكر الإدمان أو أي مرض، وكان بالأساس للمدمنين الموقوفين المحكومين نتيجة استهلاك المخدرات. دونك كان فما تخوف ممكن من الرأي العام وشنو الرد الفعل متاعو، لماذا نهتم بهذه الفئة التي تتعاطى مواد ممنوعة معتبرة كجريمة. دونك القنب الهندي كان اسمه مخدرات، إلى حد الآن المرضى متاعنا يقولوا مخدرات للقنب الهندي. دونك الكلمة في حد ذاتها كانت تفجع، العائلات كانت مفجوعة، واحنا زاده اول مره يدخلوا لنا المساجين باش نقول مساجين المرضى نتاعنا كانت في صوره خايبه برشا بما انهم مساجين وكل، لكن هذه الصوره بعدنا عليها برشا. ونتيجه النضالات في الجمعيات زاده عندها دور كبير معناها في اتيوست باش نجرمنا ننجحوا في مقاربه تقليص المخاطر. انا ككاتبه عامه سابقا وقع الاتصال بي من رئيس مركز، والكلمة في حد ذاتها تفجع، ما عنديش تعامل مع الأمن، لكن نتيجة التكوين عرفنا أنه لابد من القيام بتحسيس دورات تحسيسية للمتدخلين كفرق مختصة في مقاومة الإدمان. ونتيجة الدراسات هذه ولا المناصرة اللي كنا نعملوا فيها معناها الأيام لمناصرة استعمال المواد ولا العلاج الناهض للأفيونات أو غيره كل، والتعامل مع قضاة ومع الصحافة ومع الكل، ومعطيناهم دورات معناها حابين نفسروا لهم شنو الفرق ما بين اللي يتاجر بالمخدرات وما بين اللي يدمن. وحاولنا ساعات انه الادمان نحطوه معناها التدخين ادمان، لكن قاعدين نبيعوا امر سهل جدا. الالكول كيف الكحول ادمان، والسلوكات بدون مواد ادمان. دونك المرض هذايا الشباب الكل من الاول ينجم يدخل في حاجات اللي توصلوا للادمان، وحاولنا نوريهم الجوانب نتاع المرض وكل، ولقينا تفاعل جيد. والامنيين توا الفرق المختصه يقولوا لنا انه ما ندخلوش، راهو كوش كان جاي في طريق معناها ما نوقفوش وما نتبعوش واحد لمجرد الاستهلاك. وفعلا ما لقيناش تتبعات. احنا مثلا في تونس الاطباء والمدمنين عندنا قوانين تتضارب، مثلا لابد من ديزون الديكلاراسيون الاعلان ولا على الشخص اللي يتقدم للعلاج، هذا قانون. في نفس الوقت عندنا قانون سريه المهنه، دونك ما لازمناش نعلنوا. هنا لقينا المخرج انه هو المطلب الرسمي، دونك احنا ننصحوا المريض نتاعنا باش يعمل المطلب الرسمي هذا في العلاج، او كمن جهه احنا كمتدخلين قام الاعلان، وهو قام بالاعلان في حد ذاته، لكن مرينا حتى تتبعات ونتائج سلبيه فيما بعد. دونك ما يقاش تتبعهم اللي يجيونا، بالعكس هما يتمارسوا يجيوا وياخذوا النقل العمومي ويقع الى فما نقاط تفتيش او غيره، ويقولوا اللي هما ماشيين للمركز نتاعنا، لكن ما فما حتى تقلقات. دونك بعدنا عليها برشا وقاعدين باقي نواصلوا في الاتجاه هذا. القانون نتاعنا زاد تطور، خاطر في 2017 احنا كل مره نحاولوا باش نعملوا تغيير للقانون ككل، لكن ما نتحصلوش على هذا اللي نطمحوا له الكل. لكن فما بنود كما في 2017 القضاة تمكنوا من امكانيه النظر في ظروف التخفيف، ومن غادي دونك الاحكام نتاعنا ولات بسيطه، وساعات حتى القاضي نجم يوجه العلاج بدون حكم، دونك ينصحوا باش يمشي للعلاج، ولات فما اشهر والا جست مده الايقاف اللي هو توقف فيها يحكم عليه بها واللي هي قصيره نتاع شهر واثنين، دونك يجيو للعلاج. المقاربه نتاعنا ولات اكثر ماشيه نحو العلاج مش في الردع والاحكام الجذريه. وشكرا.
Thank you very much. I can imagine that even if there are no negative repercussions, the fact that people need to declare to the security forces when they seek treatment, that could be a big disincentive to seeking treatment. We have a question from Ms. Quds Brahimi.
Sorry, I will speak in Arabic. هو ليس بسؤال ولكن على الأقل بعض الملاحظات في السياق العام التونسي. كل شكر موجه لجمعية أتيوست على العمل الكبير اللي تقوموا فيه، ولكن على الأقل في الإطار أو السياق القانوني في تونس، خاصة في القانون 52 اللي يتعلق بتجريم استعمال المخدرات في تونس. بعد العديد معناها من حملات المناصرة في تونس أتت معناها هذه الحملات بأكلها، خاصة وأنه المشكل في القانون التونسي هو أنه يتم تبويب المخدرات صنف A صنف B صنف G. فبعد حملات المناصرة تم النظر في تخفيف في العقوبات، مثلا مش نفس الشخص الذي يستهلك القنب الهندي يسمى بالزطلة باللغة التونسية، كانت عادة معناها يصير عليه أحكام تصل إلى 5-6 سنوات، ولكن بعد أعمال المناصرة أصبح هنالك التخفيف في الحكم، وإن تم معناها الإمساك بالشخص وهو تحت الإدمان عادة ما يكون إذا كانت أول مرة يعني يتم تحريره، ولكن إذا كان ثاني أو ثالث مرة أو رابع مرة أعتقد أنه صارت العديد من الحالات على الأقل بالنسبة للاتيال أنه زج بهم للسجن. والمشكلة إذا تم الزج معناه بشخص مدمن وعنده مرض في الاستهلاك، انه حتى في داخل السجن في تونس معناها لا يتم تفريق بين الاشخاص اللي يتعاطون المخدرات، تلقاه مع اشخاص مرتكبي جرائم قتل او الى اخره. وهذا هي مشكلتنا في سياسات الدولة التونسية. على الأقل بالنسبة للمخدرات اللي يتم أكثر استهلاك في تونس هي بصفة رئيسية سوبيتكس، الإكستا، الكوكايين، الكريستال والإيريكا والبوبيرز. معناها هذوما 5 مخدرات، وعادة تلقى نفس الشخص يعمل ميلانج كبير في المخدرات هذه، خاصة فيما يخص معناها ممارسات جديدة للمجتمع معين في تونس، هو معناها استهلاك البوبيرز مع الكريستال والكوكايين. نقطة أخيرة في علاقة بالمركز المركز التونسي أو المنظمة التونسية للإدمان اللي لعبت الحقيقة دور كبير في تونس في حملات المناصرة مع أتيوست والعديد من مؤسسات المجتمع المدني في إدخال الميثادون لتونس، وخاصة في إنشاء مركز تانيت، هو أول مركز في تونس موجه للنساء اللواتي يتعاطين المخدرات عبر الحقن، وموجه أيضا لصغارهم. ولكن المشكلة تبقى في الميثادون اللي هي في مركز حكومي خارج تونس، هو يقع تحديدا في منطقة بنزرت والتي تبعد أكثر من 60 كيلومتر على منطقة تونس، في منطقة ريفية يسمى بجبل الوسط، وهو تقريبا ماهوش معناها مجاني. وطاقة استيعاب هذا المركز كبيرة جدا، وصعب جدا اللي أنت معناها تلقى وأماكنه جد محدودة. فالآن المناصرة هي على أنه المجتمع المدني التونسي هو اللي يقوم بإعطاء الميثادون مثل البريب. ولكن المشكلة يمكن الصعوبة اللي تواجهها تونس حاليا خاصة في الأشخاص اللي يستهلكوا المخدرات عبر الحقن هو أنه معناها الجلوبال فاند هو الآن يعني باش يخرج من تونس وباش يخلي، أنا نتوقع اللي هو باش يخلي فجوة كبيرة وكبيرة جدا. نعتقد أنه معناها الرؤية الاستراتيجية هو كيفية تعويض التمويلات اللي كانت تضخ من الصندوق العالمي خاصة بالنسبة للأشخاص اللي يستهلكوا المخدرات عبر الحقن. شكرا.
Thank you very much. Caroline, I think you wanted to add something?
Yes, actually, I have three questions. I apologize, accumulated over the last few presentations. Number one, to Ellie and to anyone else that is considering updating some of these prevention kits and response kits, updating it for the proliferation of synthetic drugs. What exactly do you see is necessary? What sorts of equipment, what sorts of products could be included in these kits? And then also regarding the supply chain, what are the challenges with acquiring some of these materials that are needed? For example, I know in Europe, as many European countries have prepared themselves for the proliferation of synthetic drugs, especially drugs like nitazines that are very dangerous, there has been a call for increased pharmaceutical and industrial production of overdose reversal drugs. Is something like that needed in the region? Do you see limitations and possibilities? That's my first question. My second question is about Iraq, because I think in the region, Iraq is one of the countries that is perhaps in one of the most difficult positions geographically, because you have the flow of methamphetamine from one side, you're bordering Iran, there's a huge proliferation in Basra. Meanwhile, on the other side, you with Syria and then also some transit through Turkey, you have the flow of methamphetamine and Captagon. There was a recent UNODC report, I forget the exact statistic, but they did a search and a review of Captagon and methamphetamine proliferation in Iraq, and the numbers were staggering in terms of demand and consumption levels. It's hard to know the exact numbers, but given that it's been over half a year since the fall of the Assad regime, from your perspective, from a consumption perspective, have you seen an increase in consumption and demand of Captagon and possibly methamphetamine? Have there been any effects from what we've seen in Iran? There's been a lot happening in Iran recently. Have you seen any sort of noticeable change in this first half of 2025 with consumption trends for Captagon and methamphetamine? And then finally, and I'll try and make this last question brief, something that we're also looking at is the crime and conflict nexus, the relationship between crime and these flows and violence, and how many of these criminal actors are imposing costs to local communities. Some of these criminal actors are armed, they can become violent, and they can impose some pretty severe costs to local communities. For everyone, has there been any sort of observation about the patterns in which these criminal actors operate? How are the consumers affected? How are local communities affected, especially when talking about actors that are operating within militia structures and have control and political influence in local communities? Just wanted to throw out that last question.
Thanks very much. Let's go to Ellie on the first and maybe third question, and then to Zina for the question about Iraq. And if anyone wants to come in on the crime conflict nexus, please just raise your nameplate.
I'll start by the obstacles of the supply chain. First, maybe we have three obstacles or limitation. The least one is that to find a culturally sensitive kit or material that we can use without somehow getting anybody upset. The main issue is the security situation. I can give you an example of our colleagues in Jordan. We started with them distributing syringes many years ago. Then we found lots of obstacles from the security until they had to stop this service. So the problem of dealing with the law enforcement is very important for us, and I think it should go in the recommendations. Dealing with them, we have some experiences. For example, Lebanon has, MENA has a law enforcement network, and they have a expert community group. Muhammad is one of them. They are law enforcement judges, prosecutors, and lawyers. And we did a huge important work until COVID arrives. And this is how we had to stop it. And again, when the police officer, you work with him or with her, let's say, for many years, once they are convinced, they shift them to another position, and you have to deal with the new people. So this is a big problem. And one of the recommendations of the last consultation meeting with law enforcement was to train the police officers when they want to deal with the issues related to drugs, not only from a law perspective, but also from public health and human rights perspective. And this is how we want to emphasize what is called the social policing or something like that. So this is the second issue. The third issue is the financing. As Quds mentioned, now we are witnessing the withdrawal of donors from the region, and this is very threatening, especially for the civil society. Maybe they have fund for, let's say, ARV. They have fund somehow for, I'm not sure, for rehab and detox, but they don't have fund for the civil society to do what the governments can do, to go in the street, to do outreach work. Now, we were discussing with Nadia, they are waiting, expecting a donation from Apoticom, the injecting kits, okay? We are dealing with the Minister of Health, who is convinced, but he doesn't want to take the decision to accept this donation. He has to go to the Minister of Interior Affairs to get his approval. This is unacceptable when we're dealing with a health issue. We have a successful story. In Lebanon, for example, the civil society advocated, and we got a decision from the Minister of Interior addressing the police not to interfere in case of overdose, because this is a health issue. And another one from the Minister of Public Health for the healthcare providers not to call the police in front of an overdose situation, because we need to secure the confidentiality of the patients. So we have some, but the problem is when it comes to the police, it stopped there, you know? I don't know if...
One more thing, because you were asking about type of harm reduction kit that we need. I think before answering this question, we should know more about the trends and what type of how they are using amphetamine or methamphetamine nowadays. For example, yesterday you were talking about if it is available, the liquid. Methamphetamine, it's not available liquid in Lebanon, but you have GHB liquid, you have ketamine liquid, and ketamine you can inject it as well. And all of this are part of all these stimulant effects. You sniff more, but also you do an anal injection. I don't know what is the terminology, scientific terminology, but anal injection to have to speed the effects of amphetamine, for example, or other substance. So all these, like how people are using them, we need to find these more and to understand in order to bring a typical harm reduction kit and to convince people to use it. And here we use usually a peer educator, like what Achos was saying, peer educator that are trained to do all of this. But all of this, it's not legal. So it is under the table, and this is why it's hard for us also to reach out to this community to reduce their harm, because it is always drugs. It's about police matter. It's about criminalizing people, not looking at it as a health issue, a public health issue, or a human rights issue.
Thanks. And Zina, would you like to come in quickly on Iraq?
بالعراق بعد أحداث بالعراق بعد أحداث سوريا الدولة بلشت تعلن قد ايه نسبة إلقاء القبض على التجار والمواد المخدرة اللي فاتت عن طريق سوريا. فبلش الإعلان عن كميات كبيرة. بلش الإعلان بمارس، آخر شيء بمارس ب 2156 طن من المواد المخدرة ما قسموها، والقبض على تجار دوليين بال 1194 تاجر دولي و 1365 تاجر محلي. بلش الإعلان بعد سقوط سوريا وبعد الحرب إيران إنه في كتير معلومات بلشت عن إنه عمليات ضبط مواد مخدرة وتهريب وتجار. وبلش العملية إنه هلا بدنا ندخل على البروسيجر التوعية للفئات اللي عم تتعاطى هاي الأدوية، وكيف بدنا نقضي عليها نهائيا بالتعاون مع الدولة والجهاز الأمني. فهون عم اقول لك انه جاء من دور المجتمع المدني، انه نحن بحاجه انه تونس هلا عم اسمع تونس كثير عندها اشياء متطوره وللنساء ولمراكز. العراق عنده مراكز حكوميه لكن تفتقر الى هذه التكنيك. لا يوجد للمجتمع المحلي اصلا هيك، يعني الجمعيات ما عندها هيك مراكز انه هي تكون مسانده مع الدوله بهذا القطاع. فما يوجد تعاون. نحن بعيدين كثير بعد انه عن هذا الموجود بالدول المجاوره كلبنان ولا تونس، ولا نحن هلا عم نشوف انه نحن كثير بعيدين وما يوجد اي خط استراتيجي او خطه للقضاء او التوعيه عن المواد المخدره. فهي الحاجه فهي كثير يعني كثير مهمه حاليا، لانه في تعاون مع الدوله مبدئيا، بما انه دول الجوار نحن بنكيف على مصايب دول الجوار. فبما انه في مشاكل انه بايران وفي مشاكل كانت بسوريا، هلا شوي انه الحدود خلينا نقول تقنيا مضبوطه، يعني في على الحدود في ضبط اكثر وفي القاء قبض على التجار والتهريب.
Thank you very much. We now have a presentation on wastewater analysis and other scientific analysis by Dr. Bilal Mosla. So please, over to you.
Thank you very much. So, Dr. Bilal Mosla, researcher and toxicologist at the Center Mahmoud Yaqub for Emergency Medical Assistance. So my presentation includes some animation, so I hope that we manage this with Anna. Okay. Anna, next please. So all we know, the conventional or the classic indicator to monitor illicit drug use or consumption, we found forensic toxicology laboratory reports, school-based survey like the MedSpot survey, drug seizure, and custom data. However, next please, Anna, animation. Yes. However, nowadays there are some new and innovative indicator like hospital emergency data, web survey, and syringe analysis. And the most maybe new one is the wastewater-based epidemiology. since the wastewater is maybe the sample that reflect more the general population. It's a kind of the urine of the general population. So that's why we go to the influent wastewater to get the biggest picture of the drug consumption. Anna, next, please. So today I will speak about wastewater analysis and syringe analysis, the two big projects. Anna, next, please. So the first project on wastewater-based epidemiology, it was with partnership with the European Union Drug Agency and also with the Group Pompidou MEDNET program. Yes, next, please. So these are the sampling in 2022. We get influent sample from 6 cities in Tunis. We cover the major city in Tunis, where there are the big population. So in total, we get 15 wastewater treatment plants. We, of course, followed the European Network Sewage Analysis Group protocol to do the sampling. We get sample from 7 consecutive days for each wastewater treatment plant. So in total, we got 105 sample analyzed. This sampling was with collaboration with our National Office of Sanitation. Yes, Anna, next, please. So I will not focus on this because this is the equation that we can go from the concentration in nanogram per liter in the effluent sample to calculate in milligram per day per 1,000 inhabitants. We take into account many parameters like the flow rate of wastewater entering the wastewater treatment plant, the concentration of the metabolite, because we need to quantify the concentration of the major metabolite of the drug, not the drug. This is the kind of pharmacokinetics. We have to do some calculation. So to go directly to the result, maybe. Next, Anna, please. So the final objective of this work is to implement an interactive cartography for the real-time monitoring of community consumption of a listed drug, covering the major Tunisian cities. The next, please. So here I give you one example from the spot that we can quantify. So here we have the cocaine consumption in milligram per day per 1,000 inhabitants for almost the region that we examined. Next, please, for the MDMA. So I have just to say to remind that the consumption of cocaine was done by calculating the concentration of its major metabolite, benzoyl agonine. This is the conception of the methodology of wastewater-based epidemiology. So this is for ecstasy, the result. For amphetamine, next please, Anna. And there is many use of amphetamine in Tunisia. We can be confirmed in wastewater. However, for methamphetamine, not yet. Next, Anna, please. Yes, for we only detect methamphetamine in one region. It was a touristic region, this one, a touristic region. It's the region of Hammamet. There is many hostels. Yes. And for cannabis, next, Anna, please. For cannabis, as you can remark, the consumption is in gram per day per 1,000 inhabitants. As you know, the cannabis is not in milligram, but in gram per day per 1,000. You know, the cannabis, it's the most used drug in comparison to all others listed drug. Okay, Anna, please, thank you. So here we also did a comparison, the consumption between the consumption during the week and among the weekend. As you can see, there is an increase of stimulant consumption during the weekend, Saturday and Sunday. For example, we have amphetamine and ecstasy for the wastewater treatment plant number 3. So we have this phenomena of the increase of stimulant during the weekends. This is the first assessment. Next, Anna, please. Yes, the same phenomena. Next, please, there is animation. Yes. So the same phenomena of the increase of stimulant in the weekend for the MPS, because we also perform a qualitative analysis of new psychoactive substances. We screened more than 50 NPS, and we could detect 16, but these 16 are classified. They cover almost more the classes: synthetic opioid, synthetic cathinone, amphetamine derivative, and synthetic cannabinoid. We can see that this phenomena of stimulant use still persist in the weekend. Like, for example, we can find pentadone, metcathinone, the 4-MMC during the weekend. We can find also the HMMA and the pentylone. So this phenomena is confirmed for traditional illicit drug and for new psychoactive substance during the weekend. Okay, Anna? Yes, so here we also assessed the impact of pandemic COVID-19 before and after COVID, since we performed two sample campaign before the COVID-19 and after or the post-lockdown sampling, and we can confirm that there is an increase of stimulant use during the COVID-19, because most of people are still at home, so they have like a change in behavior. So that's why we found more use of stimulant during the pandemic. Next, please. So now let's go to the second project on syringe analysis. This project was in collaboration with our colleague from Atos. I take this occasion to thank them again. Yes, to provide us the syringe, because this is one of the major steps of the work. And then this work was in partnership with the European Union Drug Agency in the framework of the European for Monitoring Drug and the ESCAPE project. Thank you, Anne, for your partnership. So, Anna, please. Yes, so this is the sampling. We collect in collaboration with the Atos more than 250 syringes distributed to 5 most popular districts in the capital, Tunis. Anne, please, next. Yes, next. Next, please. Yes, we followed the generic protocol given by the European Drug Agency. Next, please. And of course, we respected the security guideline. Next, please, Anne. Yes, this is, I will not focus. This is the preparation of the syringes. Next, Anne. And then this is the analysis by LCMSMS. Next, Anne, please. Yeah, this is maybe a little bit important. After we get the result, we import the result found one by one to the ESCAPE platform. And then, next, Anne. And then you can see here, we have 2 campaigns in the context of the ESCAPE project. We have campaign in 2023 and 1 campaign in 2024. We have all the results are here. We can go enter and check all the results online. And the platform can give you the opportunity to visualize all the data that we found. Next, please. Yes, these are the results. So we found in 2024 cocaine first with 37% injected, and then we found buprenorphine. In 2022, buprenorphine was the first. And then we found heroin with 12% and methamphetamine with 2%. And we can find after tramadol and some other MPs. Okay, so next one, please. Yes. So see, these are the same statistic, but by region. This is very important. And next, please, there is an animation here. Anna, please. Yes. As you can see here in the region of Zaharoni, we found an exclusive detection of heroin in this region, and we didn't find heroin in the other region. Anna, please. So I would like to show you another phenomenon, which is the multi-substance detection by the same syringes. Here we can find that 17% of syringes that didn't include any substances. However, there is some animation here, please, Anna. You can achieve all the animation. Yes, you can go. Yes, 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 okay, perfect. So here we can remark that more than 45% of syringes contain at least two substances. This is mean two hypotheses. The first hypothesis that people inject a cocktail or mixed substance for the same syringe, or the second hypothesis that people who inject drug share the same syringe. And here we can speak about the risk of viral contamination like HIV or hepatitis C. So this phenomena was confirmed. The next slide, please, Anna. So you can see here in the by region, this distribution by region. We can remark in the same region of Zaharoni, we have this the extent of this phenomena of polysubstance detection in the region of Zaharoni. Next one. Yes. So we have two remarks in this region of Zaharoni. There is the exclusive detection of heroin, and there is also the phenomena of polysubstance detection in the same region. And next, yes, we can confirm this phenomena of Zaharoni by this statistic that I did with R software. This statistic consists of note before the analysis, the characteristic of syringe just by eye. You can see here, for example, if there is a blood trace or the needle, and you can see here that most of syringe has a visible gradation. That means most of syringes are recent, and most of syringes are not damaged. However, for the region of Zaharoni, next please, and one animation. Yes, for the region of Zaharoni, that show the most detection of blood traces. That's confirm the phenomena of polysubstance detection in the region of Zaharoni. Yes. Next, please, Anna. Yes. Yeah, here I just make a comparison between the campaign of 2023 and 2024. So you can see here there is emergence of heroin detection from 0% to 12%, and there is a surge of cocaine consumption from 1 to 37%. So there is really a convergence where the Europe result more than these are the typical Europe result now. Because before, as you can see, tramadol and buprenorphine, they are opiate. We can misuse of this drug, and the recent campaign, we can see that we start to use heroin and we start to use cocaine. Yes, next, Anna, please. Yes, next. Yes, next. Yeah, this is here. I just make a like statistic about the adulteration for each drug. You know, all of us, that some adulteration are more toxic than the drug on itself. So you can see here for methamphetamine, for example, many paracetamol and lidocaine. For cocaine, there is levamisole, and for buprenorphine, atropine. Yes, okay. Next, please. Yeah, to conclude, as I said, there is a convergence in the last campaign of syringe convergence with trends found in Europe. There is a widespread of polysubstance detection, but the most important conclusion is the presence of localized drug market requiring targeted harm reduction approach. For example, there is a geographic disparity, particularly in the Zahroni, where heroin and its major metabolite and the combination opiate and benzodiazepine is very dangerous. Reveal existence of distinct local drug market and specific user behavior. These call for risk reduction strategy to each area. So we have to target harm reduction approach even inside the same country for each region, not the same harm reduction approach. Yes. Next, please, Anna. Yeah, for the recommendation, as I said, is to expand access to sterile injection equipment, naloxone for overdose prevention and opioid substitution. We have to really start to develop targeted and multidimensional harm reduction approach, and to establish an early warning system specific to Tunisia. Next, please, Anna. So we already started with this work about the early warning system, and actually I'm writing a paper on how to integrate multi-source data stream, like for an advanced illicit drug surveillance dashboard. As you can see here, I tried to combine all sources stream data from different sources of information. We include the syringe analysis, wastewater, forensic data, hospital emergency, web survey, and drug seizure. That means I include both supply data and demand data for the same engine. And then the second step is to make the triangulation of this data and start to make cross-validation of this data, and to try to find really get the big picture from that means sometimes the result of syringe seems to be contradictory to the result of wastewater, but in reality they are complementary to the wastewater and data. Yes, next, Anna, please. So for more detail, you can download this regional report by the European Union Drug Agency. We can find some of our results here. An overview of drug market in the European and neighborhood policy South countries. Next, Anna, please. You can also find more result and more data on, you can download this paper on my profile, ResearchGate profile. Most of the results you can find it here, except of the latest one that are not published yet. Yes, thank you. Thank you very much.
Thank you very much. Some very interesting insights there, and I think it just goes to show what these methods can show. I'm not sure that there is similar capacity in every country, so very, very interesting. Maybe we can have indeed some recommendations in increasing wastewater analysis in the report. Complementing, of course, general population surveys and other means of assessing the usage in the population, which is, I think, more accurate than looking at seizure data, for example, and arrests. I'm going to propose a small change to the agenda, if you'll permit me, and I'd like to propose that we now move to the presentation by Adria on the Global Drug Policy Index. And that will mean that after lunch, then we have the remainder of the time for open discussion. So Adria, if you agree, could we go next to you on your presentation on the Global Drug Policy Index? Sure. While Adria is getting his presentation up, we can have a question on the on what we've just heard about wastewater sampling. Go ahead.
Thank you so much, Doctor, for the presentation and for the insightful inputs. Maybe one question that came to my head after the presentation about the aspect of social and economic analysis, maybe of the results that we've seen in the presentation, and like the reasons why in some areas there is the increase consuming of cocaine or other substance either than other areas, for example. Like, is there like a social economic analysis of the results you've done?
My work is just focalizing on doing analysis and get some answers, scientific answer, but this kind of interpretation, maybe I'm not really expert to do this kind of interpretation. However, what I am sure when I am analyzing the result from different sources of I found that there is really more availability of cocaine more than the last year. For example, heroin also, before 2 or 3 years, heroin, it's not, because I did many sampling campaign from 2012 and 14, 17. So I have the result, I have a monitoring of 10 years on wastewater, but the results that I found in 24 are really the most, I said, particularly for heroin and for cocaine. We can say that really there is big availability of cocaine nowadays more than 10 years before.
Honestly, yeah.
The question of purity of cocaine in the market now, it's very important because, you know, when I analyzed the cocaine, I found that maybe it's not pure more than 40% or 30%, and the rest is adulteration. So that's why maybe it is more available. It's cheaper. When it is cheaper, it's more available. Maybe this is maybe scientific, more scientific interpretation than socio. I don't know.
Yeah, I asked the question because honestly, it's surprising to see areas like Zahroni, Haya Hilal, and other popular cities and areas in Tunis where you cannot afford this type of substance and drugs. Cocaine is very expensive in Tunisia. Maybe it become cheaper nowadays, but still it's not very available to this vulnerable population and marginalized population. That's why.
I can confirm that in my first campaign in wastewater, it was in 2020, in 2022. So I found cocaine only in some region, specific region, that are really, it's a rich people, not popular district, you know. But now the cocaine, it's really inside the popular district. not only in that region. It's widespread. Yeah.
Thank you so much.
Just to clarify things when it comes to cocaine, I think it's not the pure one. We called in our Tunisian language is the dirty one. So it's not the same. While can rich people reach out and can find it. So it's the dirty one. It's a combination of erica. It's a combination of a lot of another substance. So it's not the pure cocaine. Just for make things clear.
Just to say that one of the needs in the region is to have a drug check spot. We knew we had a law enforcement visit to Amsterdam to see the drug policy, and there we understood from one of the smart coffee shop that they send the drug, the cannabis that is imported from Morocco to Spain to get checked before receiving it. So in the region, we don't have any spot for drug check. I think this is important as well.
Thanks. Another recommendation there for the report. So let's pass to Adria. And Adria, if I to please be as quick as you can while not speaking too quickly, otherwise I get in trouble with the translators.
Sure, no problem. Yeah, so thank you for this, and yeah, good afternoon again to everyone. Just thank you also to EU and to the European Commission for organizing this. I think we all know how hard it is to have these spaces and how much work it takes, but it always pays off. There's always reward for it. So yeah, thank you for doing that. So yeah, as I said before, my name is Adria. I work for the International Drug Policy Consortium. We're a network of NGOs from all over the world. We're 200 NGOs, and we advocate for drug policy reform on the basis of public health and human rights. And I'm going to talk today about the Global Drug Policy Index, which is a project that tries to put into practice this idea of an approach to drug policy based on human rights and health. And it does it by trying to rethink how we measure the impacts of drug laws and how we talk about drugs and drug policies themselves. We could move slide, please. Yeah, so we're talking about indicators and data, and I think that means that we're going to talk about how we look at drugs. And the questions that we're going to ask are, what are we looking at when we look at drugs? Who is doing the looking? What is the intention behind looking? What is left out of our eyesight when we look at drugs? And what are the policy implications of the way that we are looking at drugs? Let's go, please, slide. Now, we launched the Global Drug Policy Index in 2021. It is, in short, an index that analyzes and assesses national drug policies against their alignment with UN pillars of health, human rights, and development. And I'm arguing today that we're trying to bring three paradigm shifts, three big changes in how we look at drugs. The first one is where we're trying to bring meaningful data, the information that has been used to assess the impact of drug policy so far. It's very much focused on law enforcement, on the tons of cocaine seized, on people arrested, or at best about drug use prevalence and the presence of substance in markets. And we're trying to do is to try to get comparable and reliable data that discuss the impact of drug policies. So what are the human rights implications of drug laws and policies? Who is left behind? Are we providing good responses? The second shift is who is doing the looking, right? So what we're trying to do here is to empower civil society and communities to hold member states and the international community accountable. And the third one is that we're trying to use the data for policy change. So this is a project that's both academic and it's a civil society advocacy initiative. And it's an advocacy project. You know, we're not just researchers. We're trying to change policies, and we are not apologetic about that. If you want to change, yeah, I don't know if you can read this very well. So the global discussion around drugs from a research perspective is very much, as we have seen today in the last days, it's captured by data around seizures, arrests, detention, interdiction. Whenever I do this presentation, I go to a country and I just do Google of the news around the drugs, and this is what I did yesterday. I searched Captagon news, and the top 4 results were Captagon bust, seized the Captagon factory, Captagon pills, thwarted attempts, etc. So this is what we have so far. And that, of course, if you can change the slide, creates two big problems for us. The first one is that, maybe not the most important one, but the first one is that it doesn't give us a good sense even of the impact of law enforcement. Because of course, seizures and arrests are the result of many factors. It can be because normally it's because there's more flow of drugs. It can be also because there's a change in the way that we enforce drug control. There's a change of priorities, switch of budgets, random facts, etc. So it doesn't tell us what we are achieving. It doesn't tell us if we are curbing the power of organized crime, etc. And then the second problem, and the one that's more important for us, is that it's a very narrow framework. It only looks at law enforcement, and it only looks at drugs. Like it only looks at the substances, but it doesn't look at anything else that is around drugs, drug use. So if you want to change slides, like when I was in a space like this a few years ago, a journalist from Uruguay called Guillermo Garat told me this sentence, which always stayed with me, which is that the word drug hides more than it reveals. It just is used, like drugs don't mean anything by themselves. They're just plants, or they are substances made in a lab. But what matters is everything else that happens around it. Why are people using? How is the state responding to use? How is law enforcement responding to it? So yeah, we're trying to break away from the drug framework only. And we're coming to it, if you could switch slides, please, with a few solutions. I could talk about this all day, so you tell me when I'm getting too long. But basically, the first thing we're trying to do is we use indicators to measure the impacts of government actions, and we're trying to hold them accountable. Secondly, we are trying to measure government action against a UN guideline on drug policy. We use and Matthew mentioned it at the start of today, the UN Common Position on Drugs, which is the common position of every single UN entity on drug policy. It's a very strong document. It's from 2018. It has like decriminalization, harm reduction, human rights at the center. So we're measuring drug policies against that standard. And another shift that we're doing is that we are collecting data relying on civil society. We speak with communities, with civil society, and that's how we get the data, rather than just relying on government sources. So if you want to change slides, the first edition of the index was launched in 2022. It is comprised of 75 indicators that are divided in 5 dimensions. You see them here. It's health and harm reduction, access to medicines, development, absence of extreme sentencing like the death penalty, and the proportionality of criminal justice measures. And the key point is that we measure all of these dimensions, both what is in the law and the policy, what's written in paper, and also we measure implementation, which is something that's had not been happening that much before. Yeah, just like another slide, please. So I'm not going to dwell a lot on this, but this is just to show you the work that we're doing. Like we have 60 years of policy debates. We have the common position on drugs, which kind of synthesizes what does it mean to look at it from a human rights perspective. We create 75 indicators, 21 policy clusters, 5 dimensions. At the end, we get 1 country score. Every country in the index gets a score. Like we rate it, but this is a result of this like long and complex process. And I'm going to end with the scores quite soon. Next slide, please. We measured 30 countries only. That is because we don't have enough money to measure more. But we're always open to getting more money and to working in more countries. At the Middle East, North Africa region, we had Lebanon and Morocco. Why we chose those countries? On the basis of 3 issues. First, we wanted countries where drug policy was very important. So, for instance, Colombia, drug policy is an essential factor in that country. Maybe not so much in Venezuela. So that's one criteria. We looked at the availability of data. So they had to be countries where there was available data already. And third, and that's maybe the most important, we wanted countries where there was a strong civil society present. presence. So that's why we did Lebanon, for instance. One of the main reasons we did Lebanon is because there's so many partners there that are fighting for the issue. Next slide, please. Just very quickly, this was the team that organized, that ran the forum with MENA, the policy with MENA in it too, of course. So it was a consortium of civil society organizations from all over the world, with organizations of people who use drugs, with harm reduction organizations, with drug policy organizations, and with the Global Drug Policy Observatory. It's once a university. So we have always like this academic on one hand and civil society on the other. Like academia is very important in here, and Swansea University, which is in the United Kingdom, really like led the process from a technical perspective. So it's a very robust project. If you want to change the slides, please. I feel like this is very boring, but just a sense of like how we got into the process, the methodology. We ran first a consultation with civil society about what should be covered. We created, secondly, a scientific advisory group with data analysts, with human rights experts, with drug policy experts, to just define the objectives. The Swansea University team designed the methodology, analyzed the UN common position, and transformed it into these 75 indicators. They started to discuss the weighting, which is a super complex issue. Like if you have 20 indicators on harm reduction and only one number, one score for harm reduction, how do you weight them? How do you aggregate them? What is more important, if there's like a opioid treatment or if there's coverage? Because as we said with Tunisia, right? Like we may have only one service, but the rest of very complicated stuff. So how do we do this? It's not a perfect way. We didn't find a perfect solution. We just found one solution. We collected data through a survey with civil society and communities, and we finalized it. Next slide, please. This is the number of respondents of the civil society survey that we ran. We had 371 responses in total. And yeah, maybe let's look at the results, please, if you want to. The slide. So these are like the highest ranking numbers and the lowest ranking numbers. It's not that interesting to look at this, to be honest, because what's interesting is to look at what's inside those figures, like how do we get that number? If you want to move to the next slide. This is the UK. You see, I'm a very diplomatic person, so I chose a country that's not part of the EU and that's not in the Middle East and Northern Africa. So this is how you see how you get to the final number. It's an aggregation of those 4 dimensions of harm reduction, proportionality, absence of extreme responses, access to medicines. One slide more, please. This is the start of how we get into the proportionality number. And these are the indicators. These are some of the first 4 indicators that we have for this dimension. So we asked people if there were cases of torture, if there was cases of arbitrary arrest. We used an indicator that already exists on fair trial. We asked how much minorities were impacted by this. And we aggregated and weighted the responses. Next slide, please. So and I'm going to finish with this, the key takeaways. It's 4, basically. Just like countries got very low scores in general. Because, punishment and repression is not great to improve human rights and health. It just does not work. Even Norway, which is the top scoring country, only got 78 out of 100, which is not great. There's lots of global inequality, lots of like disparity. It's true that most global south countries had lower scores, but that's not a given. For instance, Jamaica had the top score in terms of proportionality of criminal responses. So let's not just assume that, oh yes, this region has a more human rights approach and that other doesn't. That's not true. Like we have a mix everywhere. So just don't assume that. Drug policies always impact disproportionately marginalized groups. We all know it. Like in every single country, people who are poor are more impacted by the policing. They receive less treatment and care. Same with gender issues, of course. Same with racial and ethnic minorities. And there's a huge gap between policy and implementation. So the presentation goes on, but I'm going to finish here because I think this is a good place to end with the with these conclusions. Like if you look at drug policy with the different eyes, you see something different. It's important. The data is there. Have a look at the website. Play around. It's really fun to have a look. And also, if you want to maybe participate in the new edition of the index, yeah, it would be great. We're still looking for funding to do it, but yeah, like this is a project that's ongoing.
Thank you very much. Thank you very much, Adria, for that very interesting presentation on this index, which I think can be very useful to us from a policy perspective, engaging with these various different countries. Unfortunately, it doesn't cover every country, but for those that it does, I think it probably provides some very interesting insights, and probably breaking that down can also yield some interesting recommendations for the report based on what's the component parts of that index are. I imagine people may have some questions on the index, but I would ask you actually if you could possibly hold those because we're running over time. Unfortunately, Caroline needs to leave during the lunch break to catch her plane back. So I would maybe just before we break for lunch, pass over to Caroline for any concluding remarks from your side and some takeaways from what you've heard so far today and yesterday.
Yes, thank you. Initially, I thought I would have to leave for the airport at 3:30 after, but we just realized that to make the flight, I have to leave at 2:30. So I apologize. And hopefully I can get some summaries of the last hour. So that way we can ensure that we're incorporating everything into our recommendations. I had a few questions before about, how do we develop harm prevention and harm reduction kits. I think that definitely is something that we all need to keep looking at, and it looks like we're going to need some more research. Additionally, I would love to hear from everyone regarding about the nexus between violence and conflict and what local communities and civil society organizations are observing. I think that is something that we would very much like to incorporate into the report, especially given the fact that it does discuss the relationship between interdictions and violence, and so that's something that we would certainly like to look at. Additionally, since I think that there's a lot to be done in the frontier of developing rehabilitation and harm reduction responses, what's left? I would like to hear from everyone what's left in your mind in terms of the research and the surveys that need to be conducted on implementing effective rehabilitation and recovery services. And I'll leave it there.
Thanks. So Caroline will be around over lunch. So I'd suggest that we continue these discussions over food. It's currently 1:20, so we're running a little bit behind schedule. So I would suggest that we restart at 2:10. So if we can all be back here at 2:10, and I think Maria has an announcement.
Yeah, I have several. So first of all, if there is anything that, no, sorry, why am I doing this? Because I like to make things complicated. Since Caroline will have to leave, if there is any message that you want to pass to her in order to complete the report, you can channel them through Ellie, and Ellie will make sure that that we pass those messages to Caroline with a view for the finalization of the report. Now I'm talking about something fun. Tonight we're organizing with Anna. I've been in this hotel for 3 days. I know the walls by heart. Alas, I'm done. So with Anna, and then we're going to miss Marty because he has to leave, but we thought it would be nice tonight to go to take you for invite you for dinner. So we booked for everyone around here. For those that want to come, please make sure you tell Anna. Okay, so just so we have the right numbers. But I think it will be a nice walk around the city and and get out of this hotel that, before going to the airport, at least for me, would be nice. So we would love to have you tonight, but please let Anna know if you want to make it, okay? And now enjoy lunch, and the lunch is also to continue talking, okay? Thank you. Yeah, and we cannot be very late because I have a plane to catch.
Maria, since you are talking about logistics, can we ask you a favor to ask the hotel for late checkout tomorrow because our flight is late?
Yes, we will ask for late checkout for those that leave late. Okay. I am the one. Yes.
Between the two.
Remove the photos.
Here, just here. Yeah. Yes. Thank you. I sent you the 12 photos. Okay. I will send it to you. Yeah. Thanks so much. Do the second one.
How did you do it today? Yeah. But I mean, we can't engage with law enforcement without.
Yeah, you need to. Sorry.
No, I know. So I would suggest we get started. And I'm not sure who we still have with us or online, but please, if you're online and able to hear us, please do feel free to contribute to the discussion. And I think we can probably also give you the floor if you'd like to come in with any comments or questions, not only in the chat. So maybe just put your hand up if you can, and we'll ask the ask Anna if she can signal that to us if anyone has their hands up. But basically now we have between now and the end of the session at 3:30, so just over an hour, to talk about recommendations for dealing with Captagon and methamphetamine, whether that be in the fields of harm reduction, where you're working, and demand reduction, or whether that be in the field of law enforcement and supply reduction, because we're also very interested to take on board suggestions related to law enforcement and supply reduction, which will also be integrated into the report. Caroline unfortunately needed to leave us to go to the airport to take her plane, but we will of course report everything from this session back to her so that she can also take that on board in the report. Beyond that, and just more generally, I would also note that from the EU perspective, we're currently in the phase of developing a new EU drugs strategy. So while it's not the formal objective of today, also interested to hear any recommendations you might have for the next phase of the EU drug strategy, which will be produced by and hopefully approved by the end of this year. So if there are any thoughts on that, also interested to hear them from your side. I would, the idea is to be an informal chat conversation. So anyone who wants to jump in, please do. Otherwise, I might do a sort of tour de table and ask people if they could highlight one or two recommendations based on what they've heard so far today, or based on their knowledge of what's lacking.
Sorry, and if I may, I mean, I'm seeing myself trying to structure a report. So if you could make one recommendation at national level, but also one recommendation at regional level of what's missing and what kind of, I mean, guess you're in this side of the table, and you need to draft meaningful suggestions for a new program to engage in these things, right? Change your hat for a minute, and you have two recommendations to make: one at national level and one at regional level. And what would that be? I've been feeling like a school teacher for a week, and that's not great, but. I think that will help us a bit to focus and understand what we need. So, do we start with which country? Yeah.
Apology.
Jump in. You can stop. Yeah, you say.
No, it's okay.
Okay, so if I will talk about the regional, a regional recommendation, like one thing to start with is, until now, all our country in the MENA region, they are talking about being a trafficking route for substance use. no one is declaring as government really that we have an issue in our country. So, and if we are going to do, because you were talking about observatory, regional observatory by the ministries, Arab ministries, something like that. So I think the first one is to understand that our country is not only a route for transition, but there is consumption. And if they had this belief or this perception, it will shift the problem from a policing problem to another real a policy and a strategy to approach this program differently. So I think this mind shifting inside the regional and why it is on regional level, not national level, because like in our experience, all ministries in the MENA region, they agree on something altogether and they come back with these to implement it in each country. So we can go from regional and then it will apply positively on national. This is one. Second, I think what we need is to a national level. I have other ideas, but I will keep these two. So on national level, I will go to a maybe to think about a new model of care and new service delivery model for harm reduction in my country. To be integrated also in any new policy development related to substance use, very much tailored also.
This is exactly the kind of suggestion that we need. On the observatory, and since it was mentioned, I mean, the idea that we have is sort of a bit what we're doing in other parts of the world, and it's basically first understanding. You cannot build a regional observatory if you don't have national observatories. That's a fact. I mean, you need to build on what already exists, and we don't even know what already exists. Some of countries claim to have a national observatory. I'm not sure that they're really performing the tasks of a national observatory. And so the idea would be first to understand what exists, and then to also bring it closer to other models. I mean, Andrea, I'm sure, knows very well Plan Nacional de Drogas, but you also have in Portugal other national, those that are the focal points of the European model, right? So try to say, well, this is not something you're going to build in 6 months, right? And this cannot be led exclusively by one side of the table. It cannot be led exclusively by the Arab Interior Council. You need ministries of health, you need civil society, you need a bit in the same structure that the national, and you know much more than I do, and there are several handbooks that EUDA has done on the creation of national observatories. So the idea would be, if we get into that road, would be following that model. Yeah.
If I may, if I could push you for a third recommendation, we spoke yesterday about the training that your organization is providing to law enforcement to also help law enforcement perceive these issues in a different context and acquire new skills which maybe they don't learn through their normal training. So I don't know if you want to say maybe 2 words about that.
Yes, because we had the chance to develop a e-learning module for Police Academy in Lebanon, and it is much like they show an interest in the content, and we start to implement it. So I think adding modules on that e-learning related to what we are talking about, it will be a good step also to bring new ideas.
Can you maybe say 2 words about what already is included in that training?
It is a e-learning module that was developed on a online platform, a Moodle. It's called Moodle, and now it is run by our organization. So every policeman that attend that them to attend the training, they will have a passcode related to linked to their own email. So everyone has a password and passcode and email related to the email. And then the first session, it is face to face to present the whole module and how they can connect and how they can go module by module online. And then they are giving 2 weeks to complete the 10 lessons. So the module, it's 10 lessons, one about HIV, STIs, condom use, stigma, discrimination, substance use, mental health, self-care, SOP, vulnerable people. SOP, it's standard operational procedures that we develop with the support of MENA for police to know how they can deal with a person in the detention center or in prison if they have HIV or hepatitis, how they can protect themselves and how they can deal with these people properly. So these are the module and the content, but they are very keen to go more. So they are interested in gender perspective, how to integrate it. And they always talk about substance use, but they do a lot of, they have content on substance use, but maybe we have to develop a specific something related to for them. And I mentioned yesterday the municipality police in Lebanon, because in Lebanon, municipality police are in the community and are having like a lot of exchange with drug users in the street or with trans people in the street, with sex workers. So these also, they need to be trained as well.
Thanks. So training for police on how to deal with vulnerable populations in a sensitive way, etc. Please.
Thanks, Matthew. I think I'm going to introduce myself quickly. My name is Ahmed Shahad, and I'm the country manager for IDLO. It's International Development Law Organization, intergovernmental organization in Tunisia. Well, we are based in Italy, but we have the country office in Tunisia, and I'm happy also to be the president of MENA's board. So I'm pretty much integrated with MENA's work and mission for a long time, and very big support of that. I think I have some or few recommendations and some observations, and maybe if you allow me, maybe I can just speak about that. I think the Captagon is quite an issue that is a bit special and different from many other stories. So could you speak slowly, please, for sake of translation? Thank you. I'm sorry for that. I'm going to slow it. Yeah. So for the Captagon, I think it's a bit of a special one. It's very much of a politicized substance compared to many other substances that we have seen in the region. And I mean, talking about that is quite also very much of we see a lot of pressure on users of Captagon. We see also a lot of pressures on the producers of Captagon, exploitation of kids in producing those substances in many countries. And I mean, I see also there is as many as other substances when dealing with that is there is a lack of enough legal frameworks and policies to address the issue. Work with civil society organization, coordination between the different governmental bodies to be able to work hand in hand to address the issues of Captagon. And I think these are the issues that we currently face in many countries. Taking, for example, Tunisia, I think, this is an area where I think the civil society also face a lot of pressure in working directly with the government, unlike, for example, the Lebanese experience in building the capacity of law enforcement. I don't think here the civil society has the same luxury of working directly with law enforcement or build their capacity or sensitize them. And I think the connection is very much weak between the two different levels. One of the suggestions or one of the recommendations is that how we can build the civil society or organization capacity to be able to work directly with the drug users themselves. But then from the same time, we need also not to forget the role of the law enforcement. We can't forget also the role of the judiciary, who are adjudicating the drug users, but also the drug dealers themselves. At the same time, also lawyers, and they are very important part in providing the legal protection and legal support and representation for people who use drugs and being arrested for such use, and being also facing a lot of practices from police and law enforcement in particular. One of also of the recommendations, which is quite difficult, but this can help a lot, is that how we can think about as international organizations, as also cooperation agencies and donors, and how to build the bridges between civil society organizations and the government. To build those links between the two and make those links quite work closely. Even in some contexts, it's quite impossible and quite hard, but it's our role to build that connection and be in the middle, in the mediator role between the two. Also, let's not forget that Captagon is a substance. It has socioeconomic aspects, but in the same time, it's cross-cutting many other issues. It's cross-cutting youth exploitation, it's cross-cutting also gender-based violence, it cross-cuts a lot of other issues that we can think about and focus on. That's in 2 words or 2 cents, I would say, my recommendations.
Thank you very much. And a follow-up question. It was mentioned by you, but I also wanted to ask in Lebanon, you mentioned the absence of a legal, the need for a revised legal framework, and I note also the lack of the judiciary on all of this, which I think sometimes is an interlocutor that is missing. But how often organizations here, and I know we spoke about with Eli, for example, in Lebanon, working with Legal Agenda, working with organizations that are maybe not working on drug-related issues, but are working on policy development and legislation development. How often is that interaction, and should there be more, and how can it be promoted?
Talking about Lebanon, there is a coalition of NGOs working on drug policy, and together we submitted a new project of law. So the marge de manœuvre of the civil society organizations in Lebanon, you know it better than me. They have the freedom of, to some extent. They have, yeah. Especially now, there is a big issue with groups and community of LGBT, of course. But if you want, all what was said is very valid for me. I think I can add maybe a few ideas from MENA, but I'm sorry, I won't go into countries. But of course, MENA will be happy to help the implementation of the national recommendations. For us, we had a project since many years and we saw that there is a need for the regional observatory. But for us, the regional observatory shouldn't be looking only at the law enforcement and legal issues. It should be involving and including the civil society organizations and looking at the human rights perspective and, of course, the public health issue. The second one is the drug check spots that I talked about. There is a need, and this need starts to become very important, because we can see lots of bad products in the market, and this can affect our youth when they use it. The third one is MENA is aiming to create before the end of this year a drug policy working group to discuss the drug policy in each country, and to try to somehow collaborate with each country and support the civil society organizations to advocate and to try to work on drug policy reform. Regional working group. Of course, there are other needs in capacity building for the new trend of and new products. Many experts ignore somehow what's happening in the Captagon and Methamphetamine, and even we don't know how to treat it and how to take care of people. So there's this need. And last but not least, the financial support. If we don't have the financial support, we can't do any of this.
Thank you very much. Excellent recommendations. I wanted to pick up on something you've mentioned about the role of the judiciary, and I wondered if there are any recommendations in the realm of sentencing guidelines, alternatives to detention, penalties, etc. Does anyone have anything to say on that topic?
Just in between, but because I forgot this point, the law enforcement group or the law enforcement judges, prosecutors, and lawyers regional one that was created by MENA should be revitalized somehow, because after the COVID they were a little bit they didn't communicate. We couldn't support them, but for this visit to Amsterdam that I talked about, so we need to also support this group, because the core group that we have, they are very well convinced, and we have people that now are talking about how to have humanitarian laws.
Sorry.
MENA has a regional group of law enforcement since 2015 or 16, I think. 15. Yeah.
Regional group of law enforcement.
Yeah.
I was going to say something similar also. Elia, thank you for reminding me of that. I think when we talk about judiciary, it's not only judges, it's also prosecutors, it's also law enforcement who implement the judicial, decisions. At the same time, also are lawyers that we cannot exclude from that perspective. And I think building capacity on the sensitization of the matter and the need for taking less harsh decisions regarding users and of substances is very important. I think not only training, but also ensuring the implementation of other alternative measures is very important. I think there has been like a guideline has been in many countries has been built on alternative to prosecution. Solutions have been developed, published, but we never put that into implementation and practice. So it's not only the training first, but also training, monitoring, and accompanying the judges or the judiciary in the whole process is very important.
Thanks. And as I mentioned in my opening remarks, promoting alternatives to detention is in fact in the current EU drug strategy and in the current UN common position on drugs. Adria.
Yeah, maybe just on that, like super short footnote on the issue of training judges, etc. So we have the UN, together with the International Center for Human Rights and Drug Policy, have published a document called the International Guidelines on Human Rights and Drug Policy. It's like the standard in the world around human rights and drug policy. And they have been organizing dialogues around the world on these guidelines to sensitize government officials. Some of them have been very successful. There was a training in Pakistan recently on this. I think Pakistan is a country that the Ministry of Justice there is very open to reforms. And that was like a very good practice that happened. And maybe that's a kind of thread that you can pull and say, why don't we do the same somewhere else? Why don't we explore the same topic, same format, but in a broader group? I don't know. So maybe that's something. The guidelines are public. I think that's a short report of the Pakistan event, and I can definitely put you in touch with the people who organized it and who would be, I'm sure, going to discuss other JPP. No JPP. No. Oh, well, yeah. There, yeah. I think so. Yeah, the Pakistan people. Yeah. All right, nice one. Well, they know what it is.
Just to complement on this topic of alternatives to detention, to mention that EU Act is preparing a guide for prosecutors for the East African Association of Prosecutors on alternatives to detention. So that's something that the project is doing in another location.
I am Dr. Fa'a. I am PhD in clinical biochemistry. Okay. PhD clinical biochemistry, and I want to speak in Arabic. كنا نعرف أنه البنتاغون هو عبارة عن علاج يعطوه للأمراض النفسية. الأمراض النفسية والأطفال المصابين بالتوحد. وإنه الصفة المميزة بالكبتاغون إنه هو ينطي طاقة full energy and يسيطر، يعني يخلي شخص يركز. اوكي، يعني يعطيه تركيز عالي. فبلشوا يعطوه علم اللي عندهم فرط الحركة بالأطفال والتوحد كمن الناحية الطبية. عدا إنه الكبتاغون عكسه هو الميثامين. الميثامين هو ما يعمل تنشيط للدماغ. اوكي، عكس الكبتاغون يسيطر على الدماغ ويعمل تركيز. ولهذا هم بلشوا يستعملوه كعلاج لجماعة الأمراض النفسية. بس لسوء الاستخدام وصرف الأدوية من ناحية أنه بلدي بالعراق ما عم يصير سيطرة على الصيدليات اللي تبيع هذه العقاقير. فاللي أريده أنه عندنا شغلتين، أنه يكون تعاون بين الأمن العراقي مع وزارة الصحة مع جمعيتنا بالخصوص، وبمساعدتكم حتى نوصل لنعمل انه رعايه صحيه من خلال انه نفتح مثلا مركز رعايه باشراف يكون الوزارتين كوزاره الداخليه ووزاره الصحه معنا، حتى نعالج المدمنين ونأهلهم مستقبلا حتى يمارسوا حياتهم. النقطه الاولى من خلال يعني نسوي لهم وفد بالتوعيه، نرفدهم بالتوعيه والتدريبات. اما في حاله النقطة الثانية أنه نعمل تدريبات للشرطة المجتمعية الموجودة عندنا بالعراق حتى يقدروا يتعاملوا مع المدمنين، ويكون عزل بالسجون، لأنها حاليا بالعراق أنه عم يكون يسجن المدمنين بعد ما يلزمون من تجار أكيد أغلب تجار الكبتاغون يكونوا مدمنين، والمدمنين لما يلزموهم يحط شلون يكون الضبط عليهم بالسجن بالاختلاط مع المجرمين اصلا. فلازم يكون فصل بين المدمن مع المجرم. اوكي. اما من الناحيه الاقليميه انه نقدر انه نعمل بحوث اجتماعيه مع باقي الدول حتى نحد من اسباب وانتشار الادمان مع الشراكات الدوليه. شكرا.
One quick question. Is there a lot of avenues for regional, for local organizations working on these issues to meet and exchange, like meetings like today? How often it happens that you can confront yourselves?
It happened more than that. It happened fast because we were managing global. So it happened, but more than currently, because we were managing Global Fund grant for 5 years, and later on we were part of the MENA coalition grant, the MC MENA grant, and now everything has stopped. The new implementation map for the new grant that will start in October, we will not find any regional organization or network in this new grant, although it is multi-country addressing the civil society, but the new map has turned it to country by country work. So this is a big gap frankly, we as a coalition, the regional networks, we have reported the fund portfolio manager to the Inspector General office in the Global Fund because he was manipulating everything. So this is it. Now, if there is a support, there is a need. Frankly, we know that there is a need, but we, frankly, we cannot manage to do it by our own. We're trying to go for online meetings, but this is not much efficacious as the in-person meetings, because the interaction between people is very different. So, and we witnessed this, especially, for example, once we had a training of trainers of religious leaders. Again, MENA has a group of Muslim and Christian religious leaders. We're working with them since 2013, trying to build their capacity to have them advocating for us. And we have a group now, but once we have, during the COVID, we were training the trainers, okay? And at the end of the meeting, Sheikh from Bahrain was still online, and we said, Sheikh, where are you? He wasn't online. He wasn't there. He was just online, but not following up. So the online meetings are okay. You saw this morning, we had 40 registered. We got 20 who checked in, and now we have 11 or less, I think. So the online meetings are not, yeah. So that's it. Yeah. But yeah, there is a need. The South-South collaboration, the South-South exchanging of experience and expertise, yeah, we need it.
That's a good reminder, actually. So to anyone who is online, if you would like to come in, please don't hesitate to put your hand up or write in the chat. Yes, back to you.
No, I think I would like to follow up on the religious leaders, because I think this has been also could be a very good recommendation also here in how to address and deal with issues like the Captagon and substance use. With the religious leaders, I remember that MENA has done a unique experience in capitalizing on the work of the religious leaders as a tool that is very efficient in ensuring harm reduction in substance use or drug use. The religious leaders not only have effect on the society in general, but also they are very much considered as a leader in the communities, and they provide guidance to their communities. Issues in countries like Lebanon or Egypt, I would speak of my experience. Religious leaders have very important role in directing the society in one direction, but also impacting their perspective and on the issues or criminalization or taboo related to the issue. And I think that have been very, very important related to drug use, but also issues on HIV too. So it's still a very valid one.
I'm saying the religious leaders can influence the policy as well, so the policy makers, yeah. And we have a training package that is online, and yeah. And there is another training package for law enforcement as well that we developed in 2023, I think. Thanks.
Yes. Like to add on what have been shared, also media can play a very important role in all of this, because, for example, when Andrea was presenting, he said when he put Captagon online, he read articles about criminals, war, illegal drugs, trafficking, like that. But we do not find articles about service delivery, about people that are using drugs, what is their life, what are their struggles, what need to be changed on policy level. So involving media is very important, because media would help also to change the mentality for the grand public. Wherever we are on national or on a regional level. And also because Caroline was asking about trafficking, conflict, migration, all these are much interlinked with substance use and tailoring and having data and tailored intervention taking into concern the gender issue of gender component is very much needed. Until now, rare are like countries that link substance use to mental health. Maybe in the past 5 or 6 years, we heard people talking about mental health. WHO was involved, all international agency was involved for self-care mental health, but they don't talk about drug use. Why? Drug use is a mental health issue. So this is like the approach of like how we can have like a package, a comprehensive package of, because everything is related.
If I can, on the issue of the gender, I mean, you don't know how happy I am that I am surrounded by women today. I spent 3 days where I was almost the only woman in the room. Well, me and Caroline, basically. And I think that's important. And it's not only, I mean, it's important also, and that's something that we're finding from the project, to try to include more women in responses, in law enforcement responses, in judicial responses to security threats, including organized crime, including drug trafficking. It's not only our obligation, and it's not only a human right. It's that it's going to turn, and I'm sorry, there is evidence about this too. It's going to turn those policies more humane. It's going to increase a human rights approach to drug policies. And I assume that in your countries there are not a lot of statistics about women working in law enforcement on drug trafficking and organized crime. But I guess it's very few, no? I mean, I met some in Iraq, but it was 1 out of 100.
sorry. In Iraq we don't have ما في إحصائية للنساء حتى المدمنات أو المعنفات. ما في إحصائية واضحة. ما في إحصائية واضحة عدد النساء المعنفات أو المدمنات أو مراكز.
أو بوليس نساء.
No. في الشرطة المجتمعية فيها نساء، بس عددهم يكون شغل إداري وليس بالشوارع أو متجولين. الشغل يكون إداري حصريا بالشرطة المجتمعية. وسبب ذلك أنه ما في أصلا مراكز للنساء ليكون في شرطة نسائية تكون مسؤولة عن أسباب الإدمان أو التعنيف. فقط الرجال، لا يوجد دور النساء، فقط إداري.
I went to the counter-narcotics department of Iraq, and there was not a single woman, not one.
Thank you for raising the issue of women. I think there are 2 missing points in our discussion all the day: is the prisoners and women. We don't know what's happening in the prison in terms of Captagon or methamphetamine use or services for them. And we don't know, we didn't talk about services for women outside and inside the prisons. Here I have an information. MENA is conducting a study on harm reduction services in women's prisons. We will be releasing the report soon, hopefully. But yeah, there is a big lack in the region when we talk about services for women who use drugs, because they are really a very hidden and hard to reach group. Yeah.
Thanks. Kuds has been waiting patiently.
Actually, I will talk in a national level. So when it comes to Tunisia, I want to emphasize on something. And it's a milestone, and it's a huge impact for us to sign an agreement with the Ministry of Health. There is a systematic association working on thematic of HIV, STIs, and also drugs. We already signed this agreement with the Ministry of the Health and the Ministry of Interior. So which this agreement included that the Ministry of the Health and the government should protect the peer educators and all association working on the thematic of HIV. I think we need to take advantage when it comes to this agreement and to take the opportunity to just push. To push for low reform. I think it's time, but at the same time, we need to work on a social approach. I mean, this division of hate, the stigma and discrimination. I think it's time to work with the sociologists. I think it's time to work with them. I mean, the social approach for me, it's more important and it's more impactful, more even than the legal approach. Another key point, I think you already, Eli, you mentioned that we need to sustain our funds. I mean, without our funds, there is no services delivery related to our KPs or even for substance use. It's a key point, especially with now what happening with the global fund, and most of our money and most of our funds, it's coming from the global fund, and we need to fill in this gap. Another thing already raised by the groups here when it comes to women, I mean, we need to work on intersectionality approach. It's not about people substance use. It's about not women. It's not about just cisgender women. It's about transgender women. It's about the LGBT community. It's about female and male and the LGBT sex workers. So I mean, this is the umbrella of drugs, but there is a lot of intersectionality when it comes to the thematic of drugs, and there is a lot of exploitation when it comes to this, for specifically for sex workers and people, male or female sex workers, and even for the LGBT community. I think when it comes to the regional level, we have this campaign support don't punish. I think it's time to change this slogan. I think it's kind of old, but I think we need to change it and to reach out for more people. I think it's time to change support don't punish. I mean, maybe use another thing, but I think it's time to change it. Thank you.
Thanks. So we need a new slogan.
Yeah.
I wanted to come back to the point Adria made about the international guidelines on human rights and drugs policy, and I just wondered if there were any concrete recommendations in that guide that would be relevant to today's discussion.
This is a really hard question. So the international guidelines are a technical human rights legal document, right? So they take, they bring together all the jurisprudence of all the human rights bodies in regards to drug policy, and then synthesizes and summarize them. Definitely, I'm finding it hard to, like, definitely the criminalization issue is, I think, like the central issue when it comes to addressing drug use. It's a hard issue to engage with if the audience is not receptive, but it's I think it's a critical message that will come if you read the current text on human rights and drug policy. So not shying away from the discussion around decriminalizing, reducing contact with the police, etc. And maybe just to echo what all the colleagues have said before, the transformational power will come if we invest in community and civil society responses. If we invest, law enforcement training is useful, but it's not going to transform the situation, you know? So, yeah, like any budget that you may have that can go into that is targeted at reform, make sure that it is not spent in law enforcement as a key recipient, because we know from experience it's very hard. You know, you've been there. So like try to move it. That was not your question, but that's I'm being a politician and talking about what I want to do. No, but it's hard. I mean, I will come back to you on this because it's a good point. There's definitely plenty of good practices, and there have been many dialogues around the guidelines, and I can share some. And in West Africa, in East Africa, in Latin America, so like there's lots of good practice around this. Sorry, not a great answer. Can I just also add one thing I said before about the idea of South-South learning that Ellie mentioned before? The EU supports many cooperation instruments with EUACT, with the MENA region, and Africa, CARAP with Central Asia, COPOLAT with Latin America. Having some space of learning across people working on harm reduction in those different areas, for instance, could be very empowering. Kind of like like if we're discussing methamphetamine and harm reduction, there's so much learning in each region that's different. So that could be an initiative that could be very, very interesting to us.
On our side, even if it's, I mean, we are not focusing on harm reduction and demand. I mean, I think we're already taking a step beyond what we usually do, but I think it's needed to have the full picture. For example, this regional observatory that we are supporting in East Africa is also with the experiences of COPOLAT and of CADAP. And I know CADAP is planning soon a meeting of regional observatories in Mexico, a global one. So I'm trying to look who is going to be there and how, and how could we potentially bring people from the several networks we work with in the issue of regional observatories. Yes, but I think it's absolutely needed. Yeah. You want to go back to the issue of, but one question, and sorry if it was raised before when I was doing wedding organizing, the issue of chemsex that has been raised, I don't know if it was raised before, and the increased use of methamphetamine and chemsex, etc. What is the state of play? And I know that MENA is doing some things on chemsex. Is it something that you would link it directly to methamphetamine and Captagon trade? Thanks.
Yes, for sure, it's linked. The chemsex issue was raised when we had kind of mainstreaming activities with the LGBTQ community in five countries of the region. So it's somehow common in the five region. There is a habit or a kind of practice in the five region among especially men who have sex with men, but it's somehow also among the LGBT community. We managed to conduct a study only in Lebanon. We couldn't do it in other countries. As you know, for example, in Egypt, when we sent the questionnaire of the survey to the civil society, they were not allowed to answer us because the National AIDS Program Manager asked them not to do it, and she asked us to share with her all the protocols and all of this, the questionnaire and etc. Then she didn't answer us. So it's very difficult, very hard. But back to your question, it is related to the methamphetamine. It is related to all the stimulants used, and since it is hidden, since this community is somehow criminalized, not somehow, yeah, you cannot easily get information out of this. So yeah, this is one of the issues that we need to explore more. I told you about Mawjudun. The association here, it was called Mawjudun. It means that we exist. We started communicating with them. We signed the agreement with them. When we went to the implementation, they didn't exist anymore. They even has to leave the country. So this is a problem here in Tunis as well.
I mean, I'm sure knows more. And I'm going to speak closer to the mic and slow. If there is an issue that is starting to worry countries like Spain, where the consumption of methamphetamine is less common and Captagon almost none, the issue of chemsex is starting to be a big issue, and it's starting to worry a lot of the ministries of social affairs in Europe.
Yes, we did a study, and I will share yesterday. Maybe I talked about it. I will share the article about a chemsex study done in Lebanon and in other countries. But there were like two different type of research. One, it was done online, and it was engaging with MSM, only MSM from different countries. But the one that was done in Lebanon was more qualitative study, and it was very hard to implement it with chemsex users. And this is where we discovered more about the life struggles of these young people that started to use at very young age, and also the type of drugs that they mix together. So sometimes they use Captagon when they don't have access to amphetamine. They do also other type of drugs like ketamine and others. And each one, it's with a the mean of use, it's different. So sometimes it's injection, sometimes it's sniffing, sometimes, and they keep trying new things. And it was very hard to engage them in the study, but it is very much needed, like to have a clear component on that, and the best approach also to for any program.
I will try to give some recommendation basing on my expertise as a scientist. So I will try to extract some recommendation basing on my expertise as a scientist. So I listened very carefully this morning to the most of your intervention and feedback, and I noticed already that there is some disparities already between countries here in terms of producing data, which is the first step for all these. So for that, that's me in terms of detection technology and capability analysis. So for that, I think this could be already. I feel like in Tunisia we are a little bit in advance, one step more than the other country. So this could be already a regional recommendation to improve detection technology and. Okay. So I think that this is already could be a regional recommendation to improve the detection technology and capabilities analysis. So this is the regional recommendation. However, this does not mean that in Tunisia we have to stop innovating and stop to develop our detection capability. So already to create an observatory, I think that we have already to quantify MPS. And to quantify MPS, right now we are just making screening of MPS, qualitative analysis. So to quantify MPS, we need at least some resources. That's mean financial or equipment or something like this. It could be some standard reference. It could be some sophisticated equipment like high resolution mass spectrometry. This is in Europe to quantify NPS. This is very important to quantify NPS and consequently to create an observatory. You cannot create an observatory without data and without NPS today. Because today this is the trend. Today is the NPS. As you can see in my result, we find a lot of NPS. I didn't mention here, but I found a lot of NPS. This be used very recently in place of traditional drugs. So this is the first national recommendation. And the second national recommendation, as I said in my presentation, we need to targeted harm reduction approach even inside the country. That means even in region inside the country. We cannot use the same harm reduction approach for all the cities. We have to really to be very target. And maybe Dr. Hoyam can, if you have some recommendation in terms of harm reduction. Yeah. Okay.
I'm sorry, I missed a part of the discussion, but actually, I need to be sure that actually in 2 points, very important points I hear now. The first one is about the women, especially female in Jordan, that in fact, in practice, you can find like very high percentage of female using Captagon inside the clubs and nightclubs. And I think actually, I guess I don't have a very specific percentage, but maybe more than males using the Captagon inside the nightclubs. So it's a real problem, and it has actually every country. It has to have like a special way and a good way how to deal with a female because of the Captagon. The second thing. And I'm talking about Jordan because it's became to be a real problem in the market. Because it's cheap and it's actually gives that power, fake power. The other point is the media. It's very important, definitely is. There are so many types of media or tools can be used inside media. It's not like one way. It's actually the interviews. Maybe now it's an old school to go for an interview in the TV. Maybe there are like more catchy ways, such like podcast or so on. At the meantime, I'm pretty sure if we're going to publish a message via media, it's very dangerous to be by a policeman. It's very important to be like by a doctor to just say this is very risky for your health, not from the police, because we have the trust issue in all cases. People, especially who's using Captagon, because that gives the feeling that I know everything. So someone from the police will advise me, they will never trust. So the person is very important, the message, and the person who sent them the message via media. Thank you.
والصراحة احنا بنعيش بمنطقة يمكن واحنا جالسين تليفوناتنا بتضلها تسمعنا أخبار سيئة عن الإقليم. يعني احنا بنحضر هون بس الوجع. الصراحة هناك كل دقيقة بيجينا خبر عسكري سياسي أمني بيخلي حكينا حتى عن المخدرات ربما انه ياخذ اولويه متخلفه للوراء شيئا يعني. لكن حسب ما مداخلتي صباحا انه احنا بحاجه، اذا كنا بنحكي عن الوقايه بين مجتمعاتنا عن المخدرات، احنا بحاجه لمنهاج عربي للتوعية والتثقيف والوقاية المخدرات. إذا قد أجبت الصبح إنه في منهاج أوروبي، ربما نحن بحاجة أن يكون هذا المنهاج باللغة العربية ليتم استخدامه بسهولة من قبل المتداخلين على مختلف مستوياته. أيضا الصبح تحدثنا عن قلة البيانات وقلة المعلومات وقلة الأدلة، وبالتالي نحن بحاجة أيضا إلى تنفيذ دراسات وطنية إقليمية عن حجم هذه الظاهرة وهذه المشكلة في مجتمعاتنا، حتى تبنى مداخلاتنا على أدلة علمية وبيانات رقمية تعزز مداخلاتنا وتعزز أنشطتنا، أقلها بالمناصرة وكسب التأييد لما سندعو إليه من برامج أخرى كبرامج الحد من المخاطر. ربما التجارب أفادتنا أو علمتنا أو وصلنا إلى أننا لا نتدخل إلا حينما يتسع الرتق على الراثي، وهذا إذا عرفت الترجمة أوكي. يتسع الرتق على الراثي. يعني عندما يصل الفتق في القماش إلى حد لا يمكن إعادة خياطته. بمعنى أننا نبقى أن ننتظر وقوع مشكلة كبرى تصير صعبة على الحل كي نتدخل. وبالتالي الكبتاغون ربما اليوم هو مشكلة تفوق الهيروين وتفوق المخدرات المحقونة بسبب حجم الانتشار الهائل خصوصا بين الأطفال والمراهقين. نحن أيضا بحاجة إلى خلق نماذج من الشراكات الفاعلة وتبادل هذه الشراكات إن وجدت في الإقليم بين جميع المتداخلين سواء بالقطاع العام أو القطاع التطوعي أو حتى لم نتحدث منذ الصبيح عن القطاع الخاص، والقطاع الخاص هو أكثر المستفيدين من حالات الاستقرار والأمن والسلام القطاع الخاص، وبالتالي يجب أن يكون هناك استهداف للقطاع الخاص بطريقة أو بأخرى. الوصمة والتمييز، ونحن نتحدث كثيرا على الطاولة ربما استخدمنا ألفاظ واصمة ومميزة، وهذه الألفاظ قد تلحق الأذى بمن يستخدم المخدرات وقد تعطي الأدلة للمجتمعات لمزيد من شن الهجمات على الأشخاص اللي بيستخدموا المخدرات. وبالتالي يجب أن نصل إلى إيجاد لغة مشتركة بين الجميع تكون خالية من الوصم والتمييز وتكون منصفة وعادلة ومبنية على حقوق الإنسان، ولو أننا في هذه الأيام وبكل مصداقية نتحدث عن حقوق الإنسان بحياة، لأن كل منظومات حقوق الإنسان لم تستطع حماية المرأة ولم تستطع حماية الطفل ولم تستطع حماية كل من تضرروا بسبب ما حدث في 7 أكتوبر وما بعدها. أخيرا، قبل أسبوعين كنت في أحد مراكز الأحداث، وهو مركز يسجن فيه الأطفال أو من هم دون 18 عام بسبب استخدامهم للمخدرات، يسجنون وتحجز حريتهم في هذه المراكز. وشهدنا أثناء تواجدنا في هذا المركز بلوغ أحد الأحداث 18 عاما، وشهدنا ترحيل هذا الشخص من مركز الأحداث إلى السجن.
إصلاحي للتوضيح، مركز الأحداث إصلاحي يعني ما فيهوش سجن حقيقي يعني.
فهو تم نقله من مركز الأحداث. إذا كانوا هذا المركز زرناه على أساس أنه يقدم خدمات التأهيل في مجال استخدام المخدرات، وعندما كنا نتحدث مع هؤلاء الأطفال كانوا جميعهم استخدموا مادة الكبتاغون، جميعهم استخدموا هذه المادة. ولم نتحدث منذ الصباح عن ما هو الإجراء، كيف نتعامل، أين الأطفال في عالم الكبتاغون، وأين الأطفال في مداخلاتنا نحن جميعا كمتداخلين. ما يدعون الآن يعني لهذا الأمر أننا حتى في الأردن يعني، ولا أدري بقية الزملاء، لا يوجد مراكز تأهيل للأشخاص اللي بيستخدموا المخدرات. وكل شخص في ثقافتنا أقلها الأردنية، ولا أدري إن كان هناك غير أردنية عندها ثقافة أخرى، أن كل من يستخدم المخدرات يصنف على أنه شخص أدمن المخدرات ويتم التعامل معه كشخص مدمن للمخدرات، وهذا ما هو ساد بالثقافة المجتمعية لدينا. واتفق مع جميع الزملاء وخصوصا بالمنارة. يعني المنارة بذلت جهد كبير. إذا تحدثنا عن الإعلام، عملت في الإقليم مع رجال الإعلام أو العاملين في الإعلام. إذا تحدثنا عن رجال الدين أو القيادات الدينية، فالمنارة أعدت الأدلة وعملت مع رجال الدين. إذا تحدثنا عن رجال إنفاذ القانون، إذا تحدثنا عن القضاء، إذا تحدثنا عن النواب، كان للمنارة دور كبير. ولكن أيضا المنارة اليوم هي ما تعاني من محدودية التمويل، وقد يهدد ذلك بطريقة أو بأخرى توقف كل هذه المداخلات في ظل سياق ما يحدث بالعالم من قطع للتمويل ومحدودية التمويل. وشكرا.
Thank you very much. It's actually already 3:30 and we're supposed to end at 3:30, so we're going to need to slowly bring this meeting to a close, but we have where we can still take the two comments if they're quick. So
أشكركم لكم الجميع عن جد. أنها ملاحظات مفيدة جدا لأكثر أفهم يعني الوضع بالإقليم وخصوصا بالبلد، بسبب أنا جديد في البلد. وأنا كنت أفكر عن المعلومات، ولما نحكي عن السياسة العامة أو إصلاح السياسة العامة، تطور السياسة العامة والعمومة، في دائما هي العلاقة مع الأدراك الاجتماعية من المستوى البسيط ومن الشعب يعني. وأنا كنت أفكر عن الملاحظة عن المعلومات أو عن الحقائق. وأكيد مصدر تصليح الكيمياء إنه مهم جدا وعلمنا. وبالإضافة إلى ذلك أكيد نحكي دائما عن فينومين ظاهرة اجتماعية معقدة، وممكن مصدر واحد للمعلومات لا يكفي، صح؟ كما المثال من المؤشر المعقد يؤسسي على مصادر ثانوية، وهذا يعني طريق تالي لنشاهد للموضوع. وكثير حبيت الملاحظة عن إنه نادية الأشياء ومن قدس أيضا إنه c'est un phénomène social. وإذا آراء من العلم الاجتماعي مثلا السوسيولوجيا والأنثروبولوجيا وهكذا ممكن يكون سبيل مفيد لنفهم لنفهم أكثر الموضوع في المستوى الاجتماعي، للحصول على استراتيجية التي تترك على الأدراك الاجتماعية. هذا كان بس فكرة صغيرة من لدي. أشك.
Just for me, very short comment and a reaction to when we're talking about media narratives and also language. Just to say that There are already some standards on how to use language around drugs that's not stigmatizing, right? Like the International Network of People Who Use Drugs has a paper called Words Matter, which gives guidance. It's only in English, French, Spanish, and Russian. So maybe having an Arabic version could be very useful. And then also thinking on narratives and how people like the EU uses narratives in cooperation, just being always very careful about not doing harm with the narratives. So avoiding issues like, I heard yesterday in the cocktail colleagues talking about Captagon is flooding the region, methamphetamine is flooding the region. And that is, of course, a narrative that justifies any kind of reaction. Because if there is a flooding, you have to leave everything and just fight the flood. So yeah, just maybe also careful when we're doing that all the time, just being watchful about that. Thank you.
Words are important indeed. Very close.
No, and I think that's important. Also, the way that we conceptualize this, that we need to adapt and understand the scale of the problem and what these things are and what they're not. And as is mentioned in the report, I said at the beginning in my opening remarks, much of Captagon use from a purely medical perspective is not viewed as harmful. So we also need to bear that in mind. But we need to close here. I mean, for me, this has been enormously interesting and helpful, and it's very refreshing to get the perspectives of civil society in addition to the perspectives of law enforcement, which we've had over the preceding 2 days. Before we close, I'd just like to ask the colleagues up here with me just for some concluding remarks from their side. So maybe we can start with you if you just have any final thoughts before we close.
Yeah, thank you much. I think we get to an end where we should start working together on this matter. I think it was a very fruitful day, very informative day. We put lots of information in the same bucket, and this needs to be analyzed and maybe some dissection to find really what we can do in the near future and what we have to leave for later on, to prioritize our work and to see where are the common activities that we can conduct together. I would salute the 5 survivors on Zoom. يمكن this is the communication officer and my colleagues at MENA. I don't know who are they, but yeah, and thanks to Anna, thanks to all of you. Again, we're really happy to have this day and this collaboration with you, Maria. We're waiting for you in Lebanon, Matthew. You will come on again and again. And of course, this is not the end. As I said, we will continue together. Thank you.
Thanks very much. And indeed, this is hopefully not the end of the process. Anne, any comments from you or MD?
Very brief. One clarification, since the topic of prevention came up again, I wanted to mention that when or before we embark on training, organizing training workshops, we are very clear that the training materials need to be culturally adapted to the region, and each and every training workshop includes half a day for focus group discussion with the participants who have the opportunity to, and who are actually asked to give feedback about the learning materials and the EUPC handbook, which is meant for policymakers. So we are in the process of cultural adaptation of the EUPC, which is already available in Arabic, and we are not printing it. We are not finalizing it because the cultural adaptation process, including, data about the drug use in the region and also case studies that are contextualized and that they are not European. So this is an ongoing process. That was just the information point. But I want to join colleagues, the organizers, co-organizers, and MENA, Matthew from the European Commission, and of course Maria and Anna from EU Act, and thank them for this partnership, which I think is emerging, because for me personally it's been the first time, but it's been a pleasure to work with EU Act. And to meet Matthew and of course Eli, with whom we have an ongoing cooperation with MENA, and we are planning a webinar on a different topic. It will be to disseminate the guidance, which is more on the side of the traditional harm reduction for people who inject drugs, which of course continues to be a challenge in the region as well. So, but of course, thanks to all the participants, colleagues in Tunisia, and people online. Thank you for your active participation, and I've personally taken a lot of notes you may have noticed, and I will bring them back to Lisbon so that we can use them to inform our planning and also the discussions about the drug strategy and other similar documents. So thanks again, everyone.